Sürpriz bana ondan verdi. Bunlar ağlıyor. O tutarsa babası çıkıyor. O ne var? Dört arabalı kızı. Çikolata, yok çikolata. Bazı bu. Kırmızı da pardon pardon. Neyse. Güzel ki.
I extend a warm welcome to all participants, students, and delegates for the Emirates Pathology, Digital Pathology, Breast Pathology, Cancer, and Gastroenterology Utilitarian Conference. I am Naim Abu Freha, gastroenterologist. I will deliver this speech on behalf of the organizing committee. About the UCG conference, the UCG conference offers a wide range of events, meetings and conferences, workshops, and symposiums. We have a dedicated team who are aimed at acquiring the technologies, adopting the knowledge of business needs, and accelerating with the best ideas and strategies. The UCG is a pioneer in the area of event management and collaboration. We are a full-service event provider in the field of medical, clinical, healthcare, life science, pharma, and academia. We stand out from our competitor for our commitment to quality, round-the-clock service, and unmatched prices. We can provide you with the best event and meeting experience under one roof. We at the UCG conference make sure that you as a client choose the most appropriate event. I thank you all for finding the time in your busy schedule to be here today. Today marks the major activity in brief existence of the UCG conference, a moment where we are interacting, sharing experience, and reflecting on various areas. UCG is a remarkable event that brings together professors, researchers, students in the Emirates Pathology, Digital Pathology, Breast Pathology, Cancer, and Gastroenterology UCG conference, making the conference a perfect platform to share experience, foster collaborations across industry, academia, and evaluate emerging technology across the globe. We welcome you to join us and witness the advances in the field together. The conference attracted delegates who have come from all over the world, and the subject of the conference is surely of global importance. UCG thank all the individual and organizations who have worked to make this conference a grand success. UCG program committee has put in long hours with many creative effort, and finally, I would like to extend my appreciation to the participations of the conference. We hope you enjoy the conference and that you will be contributed to our professional development relationship. We will have amazing workshop sessions, and about these workshops. The workshop SIA Diagnostic International, establishing timing accurate diagnosis, meeting quality standards is the crucial requirement for better patient care. Radiology and pathology diagnostics are deemed to be more crucial as they are mostly dependent on the expertise and competency of reporting the radiologist and pathologist. In general, current scenario, the challenge is compounded by the availability of the trained professionals, uniformity in reporting system, quality assurance, and utility of service in remote places. SIA Diagnostic International has designed technology-driven digital diagnostic to expand horizons of possibility behind barriers. We are introducing next generation reporting system, digital diagnostic with teleradiology and telepathology service. SIA Diagnostic International is founded by visionary UK boarded certified radiologist Dr. Santosh Gordov in association with UK board certified pathology and Dr. Shilpa Santosh. The second workshop is workshop Biomerica. Biomerica, we are global biomedical technology company that develop, patent, manufactures, and markets advanced diagnostic and therapeutic products. Our products are designed to enhance the health and well-being of people while reducing total health care costs. Our primary research and development focus on GI and inflammatory diseases, where the company has multiple diagnostic and therapeutic products in clinical studies. We are an experienced and large-scale manufacturer of DE-cleared and CE market products. All of our products are CE marked for European and the rest of the world. The third workshop is Cancer Center AI. Cancer Center AI, faster cancer detection with AI. With the help of AI, our Cancer Center AI web platform assists pathologists in making faster and more accurate diagnosis through specialized models. Our platform offers an intuitive file browser and viewer for pathology and also radiology data. The future of the AI, Cancer Center AI, PathoCam, save pathology images by using your own microscope, Patho model, web viewer, analyzing radiology model, advanced AI algorithm, including Gleason score, Ki-67, and metastasis. The fourth workshop is ALCID, which include these facilities, store vast amounts of images, view images from many access points. Improve doctor-to-doctor cooperation within the organization as well as outside. Make use of computer-aided intervention tools and share the results easy. Increase output by detecting more cases in less time. Improve patient outcome thanks to personalized therapies. Enhance service quality, faster and accurate diagnosis save on cost and time by reducing patient length of stay and minimizing the resources required to treat a patient, enhance staff satisfaction by reducing manual and repetitive tasks and preventing physician burnout. And this is several notes. The speech time for speaker is 25 minutes for the speaker, 10 minutes for posters, and 25 minutes for workshops. The presentation certification will be provided after the presentation, after every presentation. The delegate and listener certification will be provided tomorrow. Online certification at the next week, 20th December, and also the accreditation and best speaker in the 20th December. And now I want to introduce the keynote speakers. The keynote speakers at the Emirates Pathology, Digital Pathology, Breast Pathology, Cancer, and Gastroenterology UCG are Dr. Eric Ebgo, Medical Director and CEO at Atlantic Medical Group. Jared Beers, Chief Operating Officer, Halia Therapeutics from the USA. Adriana Masu, Founder and CEO, Sano from Spain. Fatima Al-Darawish, Ascens Professor at the University of Chicago, Saudi Arabia. And Mikhail Retsky, Honorary Associate Professor, University College, London. Thank you all, and now we will begin the session. The first speaker is Dr. Gonel Gamarova from Azerbaijan, and the title of the speech is Mammography in Breast Cancer in Azerbaijan. Thank you.
Dear guests and colleagues, I'm so happy to have received an invitation to attend this conference. I am from Azerbaijan, and today I will be presenting my slides on behalf of Azerbaijan Medical University and Merhem Benakak International Hospital. Merhem International Hospital. Today, my team about mammography in breast cancer in Azerbaijan. I try to make our slides to short and clearly. Mammography in Azerbaijan. Please pay to my slides. Breast cancer is the first most common cancer of Azerbaijan. There are 10 million people in Azerbaijan, and 45 women include to these people. Unfortunately, to recognize an early stage in 2022, 57%. Last year, more than 8,000 people died result cancer, and more than 1,000 people died because of breast cancer. In 2022, more than 70,000 women lived more than 5 years. Also, 45 men suffer from the breast cancer in Azerbaijan. According to the latest WHO, in 2022, breast cancer death in Azerbaijan more than 2% of total deaths. Until 1976, mammography, clinical examination, and self-examination we do all. But and today, in 2023, we use mammography, tomosynthesis, ultrasonography, with MRI and CT. Please pay to this diagram. In 2012 years in total gender more than 4 million. Breast cancer, we put diagnosed breast cancer more than 4,000. In 2017, more than 4 million people, total gender people, we put diagnosed more than 5,000 to breast cancer in the woman. And unfortunately, in 2022, more than 5 million people, we put diagnosed more than 7,000 breast cancer in the woman. Please pay attention to my slides. We, in this patient, get some hamartom and hamartom in upper side of the right left mammary gland. We put down the hamartom, but in my second slide, we saw in here some microcalcification, and we do a biopsy, guide biopsy, and in this patient gets 37 years female. We put down in the screening mammography and cancer in hamartom T1 in 0M0. My second case, my patient gets some bloody nipple discharge, and in ultrasound we saw some mass in the duct, and in the patient get some claustrophobia for MRI, and we direct the patient to galactography or ductography. In ductography, we saw some filling defect and in entry in bud, and after biopsy, we put diagnose the cancer. It is my so interesting patient. In mammography, this patient use the gel, some of the lipofilling for the mammary glands, and in this mammography you can clearly see some gel in the mammary glands, but after surgery, it is surgeon's area. After surgery, we do ultrasound and MRI again, and in here we saw some microcalcification, and after biopsy we put diagnose cancer of the lipofilling area. It is our again slides. In this slides you can see some patient. In this patient gets some adenosis area in the right mammary glands, and we do tomosynthesis. In tomosynthesis, we see some microcalcification in here, and it is in this patient get genetic mutation BRCA1, and we do screening mammography and tomosynthesis, and we put diagnose cancer. Our again a patient, 48 years old in female. We do a screening mammography, and in local adenosis area, we find CR cancer, T2 and N1 and M0. It is my interesting patient. In this patient, the cat scratches the hand of the patient. After the scratches the cat, lymph nodes get inside enlarged, and during the mammography we saw some lymph nodes, pathological lymph nodes in mammography, and in ultrasound pathological lymph nodes, and we think that it is maybe an infection process in the patient, but we got biopsy because in mammography very clearly in this patient. But we got biopsy, and in biopsy we get answer occult cancer. My other patient, 43 years old female, we do screening mammography. This patient want would like to go to the reduction mammoplasty, but we find in the lymph mammal gland some some few cancer area, and we put local breast localization needle to the in the mammography, under the mammography, and after surgery we can you can see this, clearly this pathological area. And my other slides, my other slide, this patient gets some breast embrace in the right mammary gland. 12 years old and 12 years old in daughter, and 36 years old in the mom. Both of them get some breast embrace in right mammary gland, but after surgery, after secretary resection, we could diagnose some cancers area in breast embrace. Today in Azerbaijan, we also use ultrasound mammography, tomosynthesis, and MRI for diagnosis to the breast cancer. That is why in high risk as a patient, according to the American Cancer Society, MRI, we also need to MRI because before a mammoplasty, before a reduction plastic, and to could clearly diagnose for cancer, MRI give us more information, more clearly information. And for women with personal histories of breast cancer and dense breast tissue, of diagnosis before age 50, and also surveillance with breast MRI is recommended. Together, MRI and mammography, women at 50% or lower lifetime risk. What's our goal? What's the goal of the radiologists? We think that our main goal is to reduce breast disease. The main effort of radiology is to reduce the occurrence of interval cancer. And in conclusion, I want to say, remember that high-risk patients are not homogeneous group. Each patient has individual personal history, family history, and genetic background. The job of radiologists is to master all of this, and the right part of simple naming the hereditary line. Today about the dense breast cancer, and together to use mammography and MRI, the New England Journal of Medicine, you can read more information. And summary, breast cancer in 2020 in Azerbaijan get some more than 2,000 people died. More than 1,000 people in the world died. More than 6 million people in United States of America died. More than 43,000 people, and in Russian Federation and United Kingdom died more than 12,000 people by breast cancer. Early conscription in 2012 get 57%. In 2070 years get 55%, and in 2012 get some 50. More than 50%. The incidence of disease, someone at 40 age get 10%, 40 and 69 age get some more than 85%, and other incidence of breast cancer based on the patients, their organ preservation surgery account for 20%. Thank you for attention. Thank you.
Thank you for the great
Thank you.
presentation. Questions from the audience? I have two short questions. What about the adherence to screening in your country? Is the adherence high?
Yeah, we have more breast cancer. It is most common breast cancer, common cancer in Azerbaijan, and mammography in Azerbaijan there are 37 mammography now, and but that is why our screening get more few than other country. But we try in our village put mammography and put diagnosis early stage.
What about genetic testing?
Genetic, we use only genetic test. Not because of finance problem has more patient, and we direct the patient only when we think that if they get history background, genetic background, we try to direct the patient.
Another question?
I noticed several of your patients were under age 40 who would have mammography. What age do you begin screening?
In Azerbaijan, we try to direct the patient to screening more than 35 years.
35.
Because in Azerbaijan, we early marriage, more than early marriage. That is why after 35, our dens get more than fat, and to direct the screening mammography.
Okay, another question.
Sorry, good morning. My name is Noro from Ireland.
I'm so glad.
When I see your presentation, you don't mention, and I'm a pathologist, so that's why my question is about pathology.
Okay.
So I don't see anything you mentioning about multidisciplinary meeting or multidisciplinary care with clinician and pathologists, because I think for screening program anyway, we need radiologists and pathologists.
But we also work together, because in Azerbaijan there are more good pathologists, and we're working together after surgery or during the biopsy. We also contact with together.
Okay, thank you, Dr. Gumel, and you.
Thank you.
That's it.
Thank you.
Now, the next speaker, Dr. Miriam Habibi, and the title of the speech, CD45 are all cellular biomarker for larynx squamous cell carcinoma outcome.
Hi everybody. In the name of God, I'm supposed to discuss about CD45 RO positive tumor infiltrative lymphocytes, cellular biomarker for larynx squamous cell carcinoma outcome. As you know, squamous cell carcinoma of larynx is the 11th most common malignancy. The second most common site of squamous cell carcinoma in head and neck area. Despite development in treatment modalities, the 5 years survival of larynx squamous cell carcinoma patients show no improvement for decades and stood at about 60% level. Given the low survival rate, It is necessary to improve the method of risk prediction of identified patients with higher risk of recurrence and adapt prepared treatment approach for these patients. What is the tumor environment? Tumor environment is a dynamic environment, and it's composed of immune cells that are infiltrating into the tumor microenvironment during tumor growth. Several reports have shown that tumor immune microenvironment has a significant role in cancer prognosis and outcome. What is the tumor microenvironment in detail? Tumor microenvironment consists of immune cell populations, such as lymph nodes, lymphoid cells, myeloid cells. Tumor infiltrating lymphocytes are the most important component of tumor microenvironment. And in several types cancer, such as colorectal cancer, breast cancer, and lymphoma, have been reported as a potential prognostic marker with comparable or greater prognostic significance than conventional TNM staging. Recent reports indicate the greater prognostic value of tumor infiltrating lymphocyte when their subpopulation are considered. The most comprehensive study in this area was in colorectal cancer, and it is a new immune-based scoring method. In head and neck squamous cell carcinoma, head and neck squamous cell carcinoma show very high infiltrating of lymphoid cell in these tumors. The prognostic rules of tumor infiltrating lymphocytes have been evaluated in a number of studies. However, the results are controversial, which could be due to using different methodological approach to tumor site and tumor infiltrating lymphocyte subpopulation. Different subtypes of lymphocytes show different or even opposite function in TIM. What is the lymphocyte? T lymphocytes are the principal component of tumor infiltrating lymphocyte, such as cytotoxic T lymphocyte can directly target it and destroy tumor cell, and in many cancer types. The presence of CD8 positive lymphocyte in the TME has been reported to be linked to improved prognosis. CD4 cells have different subsets and play an important role in directing adaptive immune response. Studies have shown they can exert both anti-tumor and tumorigenic activities. CD45 RO positive memory T cell, other important component of tumor immune microenvironment, have shown positive effect on cancer outcome in several cancer types. In present study, we aim to study in infiltration of CD3 positive, CD8 positive, CD4 positive, and CD55 RO positive tumor infiltrating lymphocyte in larynx squamous cell carcinoma and assess their correlation with clinical pathological parameters of disease and patient's outcome. Which patient we choose? Patients with the following criteria were included in our study. Patient treated primary with surgery at first line, patient with a primary tumor without any evidence of distant metastasis, patient with complete clinical pathological data, minimum follow-up of at least 2 years for alive patients. Patients with didn't have any of aforementioned criteria were excluded. Method: hematoxylin and eosin slide section review by an expert pathologist to confirm the diagnosis, and then select FFPE, formalin fixed and paraffin embedded tissue blocks with both center of tumor and invasive margin. Finally, we choose 67 patients with appropriate FFPE tissue and complete pathological and follow-up data were included in this study. This table shows a summary of patient clinical pathological characteristics, such as male sex and staging of the tumor. Follow-up. We follow patients in period of 47 means month from 18 to 70 months. During this time, 14 cases, 22% experienced recurrence, and 22% had cancer-caused deaths. Majority of patients were TNM staging 3, and none of patients has distant metastasis. Tissue preparation and immunostudy. We choose the patient and we prepare 4 slides for each patient with 3 micrometer thickness, and then IST study for CD4, CD3, CD8, and CD45RO. Digital micrograph. We take digital micrograph for every case in 4 sessions, and we choose CD3 marker considered as the base of the slide, and select the invasive margin and central tumor region for adequate tumor cellularity, and then this is based for IST study for other markers. Then digital micrograph of other markers such as CD4, CD8, and CDRO positive RO were captured from the same region of CD3 slide. Necrotic region and area with crash and other artifacts were excluded. Quantification of tumor lymphocytes was performed with semi-automatically using ImageG software, and then employed software to capture the picture. And then analyzes my cases. All of the clinical pathologic features of the study population were categorized as binary variable and different in tumor lymphocyte infiltration between them. Cutoff point were determined using ROC curve and were calculated based on survival status. Each subpopulation of stained tumor infiltrating lymphocyte was dichotomized into low and high based into a corresponding cutoff value. Overall survival and disease-free survival were defined as the interval time between surgery and cancer-caused death or recurrence. Patients with no evidence were considered as the last follow-up and take the result in this case. CD3, CD4, CD8, and CDRO tumor infiltrating lymphocyte staining pattern. We take a picture from each case in this IST staining and take a capture and then analyzes them. The quality of the staining is evaluated by an expert pathology. Quantification of lymphocytes that are infiltrated in tumor tissue show overall higher infiltration of tumor lymphocyte in invasive margin than central tumor. However, the difference was not statistically significant. While CD45RO positive were the most frequent immune cell in both central tumor and invasive margin. CD8 positive one constitute the least frequent immune cells. This picture shows some of IST staining in invasive margin and central tumor of CD3, CD4, CD8, and CDRO. Associated of tumor infiltrating lymphocytes with clinical pathological parameters. According to the result, number of CD3 lymphocytes in CT in central tumor of poorly differentiated tumors were significantly higher than those of well or moderate differentiated tumor. Infiltration of CD4 and CD45RO positive lymphocyte in invasive margin of small cell tumor, small size tumor were significantly higher than the large tumor. Infiltration of CD4 lymphocyte was higher in central tumor of patients with lymph node metastasis. In sample from TNM staging 1 and 2, patients number of CD4 in central tumor were significantly more than those of TNM staging 3 or 4. This picture shows the histopathological age and TNM staging for free survival and disease-free survival. Prognostic significance of CD3, CD4, CD8, and CDRO tumor lymphocyte in overall survival and disease-free survival. First, we analyzed the mean frequency of immune cell infiltration between alive and expired patients, as well as patients with and without recurrence by use of MEN whitening U test. Among all studies, subpopulation number of CD45RO cells were considerably higher in invasive margin of patients who had not experienced and cancer-related deaths. For survival analysis, we determined optimal cutoff point of each subpopulation of tumor lymphocytes in low and high infiltrating tumor. Patients with low CD4 lymphocyte in invasive margin of the primary tumor had shorter overall survival and disease-free survival times in comparison of patients with highly infiltrative tumor. CD45RO positive cell in invasive margin were significantly associated with overall survival and disease-free survival. In order to find any possible prognostic rule of tumor lymphocyte, we also perform our analysis using the total number of infiltrated cells, which was calculated by summing up the number of tumor lymphocytes in invasive margin and central of tumor. Among total number of tumor lymphocytes subpopulation, CD4 cells show a significant associated with overall survival and disease-free survival. There was no significant association between clinical pathological marker and survival times. These tables show TNM staging, age, and other criteria for survival, overall survival and disease-free survival. The end, we total number of infiltrative tumor cell show the result shows CD45RO positive were independent prognostic marker for overall survival and disease-free survival. This image show CD45RO positive infiltrating a lymphocyte in overall survival. Tumor lymphocytes have been introduced an indicator of mass of host immune response against tumor cells and considered as histopathological features of solid tumor prognostic biomarker and target for immune therapy. In the present study, prognostic value of tumor lymphocytes and their correlation with clinical pathological marker were assessed in larynx squamous cell carcinoma. Our results show a higher infiltration of tumor lymphocytes in poorly differentiated tumors, especially CD3 in invasive margin. In our study, our aggressive phenotype of the disease, including advanced TNM staging, TSH and increased tumor size were associated with low infiltration of tumor lymphocyte subpopulation. And the results show CD4 tumor lymphocyte infiltration may consist of large amount of immune suppressor cells, including CD4 positive, FOXP, TD positive regulatory cell, and are associated with poor prognosis. Because of this complexity in CD4 positive function in tumor area, it can be conferred that these cells could not a good predictive of prognosis. Excuse me. So sorry. Higher number of CD45RO positive tumor lymphocytes in primary tumor may be an indicator of information of efficient anti-tumor immune response against tumor cell after removal of the primary tumor, and consequently decrease in its immune inhibitory pressure in immune cells. They may have the potential of erecting residual and recurrent tumor cells. Some of these memory cells migrate to the secondary lymph node organ and stay there as central memory T cell. Memory cells are live immune cells that after surgical resection of primary tumor have a great potential to evoke a quick response against previously considered antigen. Collectively, it can be inferred that CD45RO positive cells are a valuable biomarker for predicting prognostic of larynx squamous cell carcinoma patient, and their assessment has the potential to be integrated into clinical pathological prognostic model for patients with larynx squamous cell carcinoma. All of these indicated that new therapeutic approach by focusing on tumor infiltrating lymphocyte subpopulation can be designed to improve head and neck squamous cell carcinoma patient outcome. However, to incorporate tumor infiltrating lymphocyte in clinical predict, we suggest repeating the some work with longer sample size. Thank you for your attention.
Thank you, Dr. Mia, for the great presentation. The presentation is open for questions. Yes.
Sorry, it's me again. I just wondering, have you looked into the progression of CD45RO with status of HPV in the tumor? That's number one. And like from where I'm working, we are more actually looking into the HPV status and also the PD-L1 status of the tumor and status of CD45RO.
Excuse me, we evaluate CD45RO, CD3, CD4, and CD8. At first, we choose the CD3 in central margin and invasive margin, then choose other marker. When in same area of CD3 on the base. And then analyzes the result and we calculated that CD45RO positive is the most important relation to overall survival and disease-free survival.
Okay. Thank you for the presentation. The next, Dr. Aisha Maskiri. from the Health Science Division with the title A Cross-Sectional Study of Assessing Knowledge and Attitude Towards Screening and Prevention of Cervical Cancer Among Women in the UAE.
Good morning, everyone, and good morning to and welcome to the UAE, whoever's traveled from abroad. I'm Aisha Miskari. I'm from the Higher Colleges of Technology here in the UAE. Thank you very much for, yes, can you hear me? Okay. Thank you very much for inviting me today. Yeah. Thank you very much for inviting me today to give my talk on a cross-sectional study of assessing the knowledge and attitude towards cervical cancer screening among women here in the UAE. So I have no financial interest or relationships to disclose. So first of all, I'll just give you a brief introduction about cervical cancer around the world. It is a big, major problem, health problem. It is the fourth most frequent cancer among females worldwide. It is the second leading cause of death among women worldwide as well. And here within the GCC region, it's actually the fifth most common cancer among women aged 30 to 43 years old, 44 years old. Here's just for everyone who doesn't know, the GCC countries includes the United Arab Emirates, Oman, Saudi Arabia, Qatar, Bahrain, and Kuwait. Now, just a briefing of the cancer statistics here within the Gulf region. In the United Arab Emirates, it's the second most common cancer prevalent in women living here in the UAE. In Oman, it's the fourth most frequent cancer among all women, and yet among women around 15 to 44 years old, it's actually the fourth common cancer among them. Within Saudi Arabia, it's the eighth most frequent cancer within women. Within Qatar, it's the fifth among all women and third among women 15 to 44 years old. Bahrain, it's the fourth most common cancer, and in Kuwait, it's the eighth among all women and the third among 15 to 44 years old. So you can see that it is kind of a major problem here within the Gulf region as well. Now, we carried out a study, a cross-sectional study on university students and staff across the UAE. And basically our objective was to evaluate the cervical cancer knowledge and also to evaluate their attitude towards cervical cancer screening here within the UAE. The method, what we used was a descriptive cross-sectional study, and it was conducted among female university students and staff across the UAE from October 2022 to November 2022. What we used was an online survey, and basically we collated data on demographic characteristics, cervical cancer knowledge among these participants, and cervical cancer screening knowledge and their attitude towards it. The data was analyzed using SPSS, and then we looked into the correlation between various sections within the survey itself, and we used the chi-square test to analyze how significant these data were. Now, the survey itself was composed of multiple choice questions. It was validated internally and external, and we used, because here in the UAE, Arabic is their first language, English is their second language. Just to make it easier, we actually did use medical terms to translate Arabic words, medical terminologies. Ethical approval was obtained and consent form was embedded within the survey. So when the student or the faculty member goes online, starts the survey, they will sign a consent form first and continue on. Just as I mentioned, the survey itself was divided into three sections. The first section was where we gathered demographic details.
The second was on cervical cancer knowledge, and the third was cervical cancer screening knowledge and attitude. So I'm just going to talk about each section one by one. So within the demographic section, we asked the respondents their age, and as you can see, because we targeted universities across the UAE, majority of them were around from the age of 18 to 22 years old. Nationality, majority of them were in the UAE. Yet again, they were Emiratis. And then as it was a university, it was most of them, 83.9% of them were single. We did have 15.2% which were married. For the married individuals and separated and divorced, we did have we asked them the number of children, and we did have approximately, most of them 6.2% of them had 2 to 3 children, followed by 4.4 with no children. The level of education, so we asked them about their level of education. Most of them were graduates from school, 46% of them were graduates from school, followed by 36.7% of them had a bachelor degree. Then we just wanted to look into the field of education, whether it's health sciences or non-health sciences, because we assume that people coming from a background within health sciences would definitely have more knowledge. So the majority of them were within the health sciences division with a 66.4%. We looked at the geographic location of the individuals. So we had the majority of them, where I'm from now, is from Abu Dhabi, 40.2, followed by, we had Fujairah, we've got 16.9, and we've got Sharjah, 14.9. The next part of the survey was on where we gathered data on the cervical cancer knowledge. So we had a few questions, and I've included a few of them here. So, and as you can see that we do have the Arabic terminologies embedded into it. So the first question we asked them whether they had a family history of cervical cancer. And the reason why we asked them that is because usually if someone has a family history, they might actually have some idea or inkling into it. So the majority of them did not have a family history, and some of them we did actually leave the participant with preference not to answer if they don't want to answer. The next question, do we think that you have enough knowledge? And interestingly, we actually, this point here is where yes, but I'd still like to know more. So they do know about it, but they actually wanted to know more about it, which was actually, it's something that would give us feedback where we need to increase our awareness. And unfortunately, 40% of them did not know, but good enough that they still wanted to know about it. We then asked them which of the following risk factors have they heard of? So within our survey, what we did do is we're collecting information, but at the same time, we're using this survey to educate them. So we put down the risk factors so that we're telling them that these are the risk factors, but yet what have you heard of? So while we're gathering data, we're kind of giving them awareness so that they become aware of these things. And obviously, the majority of them went for family history of cervical cancer, and that was followed by, we've got here, weak immune system. And we've got some students and faculties who actually did not know, 140, which is a bit worrying. Now, we asked them, who do you think is more at risk of cervical cancer? And we got a variety of different answers, with the majority of them going for all women regardless of age, 38.3. And then we asked them which of the following cervical cancer treatments have they heard about, and the majority of them went for excision, followed by, we've got some of them went followed by chemotherapy, which I'm sure majority of people do know about that. But we did yet have 103 participants, which is around 9% of it, where they've not heard of any. Now, then what we did was we looked at the correlation between the demographic variables and the total cervical cancer knowledge, and we did actually find a correlation between age, nationality, level of education, geographic location, and field of education. Field of education, obviously, we've got high number of participants from health sciences, so obviously that definitely would have had a big correlation with regards to how they respond to their survey. The third section of the survey was on their knowledge and attitude towards screening of cervical cancer. And we kind of wanted to look at the barriers of what is included, what is stopping them from going for screening. So first part is, which of the following cervical cancer screening methods have you heard of? And we put them all down, and the majority of them went for visual inspection, okay, followed by the pap test. And what we did do, I've not mentioned, is throughout the survey, we actually put down details. For example, the pap test, I didn't just bring it in there. I actually put a definition and I explained to them what it was with Arabic terms within it. So it actually educates them at the same time. From where did you hear about cervical cancer screening? So the ones that did say that they've heard of it, we gathered the information to see where they've heard of it. Majority, interestingly, had heard from social media, which we can see that obviously students, and you can see how social media has a big impact on this generation. Followed by, you've got healthcare professionals and educational institutes. The next one is, which of the following facts about a pap test have you heard about? And the majority of them, as you can see, 23% of them went that all married women should have pap test. But you've got some of the participants which they've said they have not heard about the pap test, which is 159. And this is a bit concerning because we've got all these students and faculty members within the UAE, and 159% of them have not heard about it, which they should have this stage in life. The next one is, would you consider screening for cervical cancer using the pap test? Well, some of them, we do have a bit of concern is that they're no. Some of them said they don't actually want to. Some of them have not even thought about it or gone into it. And so this group of participants, we then went further on to ask them, what are the barriers? What is stopping you from going to do this? So why would you not consider screening for the pap test? And as we've seen, the majority of them, well, we've got scared of being diagnosed with it. And also we have cultural barriers, which we have seen within other studies across the Middle East, where a majority of them is cultural barriers, and they feel they can't go ahead. They feel that it's wrong due to culture. The next one is that we asked them, do you think that all women, married women within the UAE, should receive a text notification, like a message, just to remind them to go on and have their pap test from the authority here? And interesting enough, the majority of them said yes, which is a good answer. That basically it's like a little reminder for them to go ahead and have their test done. But we do have some that said no, 51 participants, which was around 9% of the total group. Then we looked at the correlation between section 1, which is the demographic, and section 3, to look at the correlation between it. And we did notice that there was a significant correlation between the age group, nationality, marital status, level of education, and field of education. Now, we went further into seeing the overall cervical cancer knowledge of these participants. And what we noticed is that the majority of them had an average knowledge of cervical cancer. We did have a high number, which is 28.5% of them having poor, and only 1.3% that actually had excellent. And this shouldn't be the case, especially when we're targeting females. So the survey was only targeted at females. So you would assume in females at the age of 19, 20 and above, you'd assume show what happened here. You'd assume at this age that participants or the respondents should have an idea about cervical cancer. So in conclusion, The majority of the participants, just as we mentioned, have had an average knowledge of cervical cancer, followed by poor, good, and then unfortunately only 1.3%, as I mentioned, had excellent knowledge. This study, the results from this study actually will increase our understanding of the knowledge and the perception of of respondents or Emiratis and non-Emiratis residing here in the UAE, of what's their perception towards cervical cancer and the screening. The findings of the study will support the UAE health authorities in the development of strategies in order to enhance cervical cancer knowledge, promote it in a positive way so that females don't feel like it's a barrier or something that they shouldn't go towards. Now, cervical cancer, as you all know, it is preventable, and it is a global incident that can be reduced through education, screening, and intervention. And I think this is part of what we need to do now. Okay, these are my references, and I'd just like to acknowledge my colleagues at the college itself. And thank you very much. Sure, that's
Any questions?
Thank you so much for your speech.
You're welcome.
So very interesting. Do you do any kind of testing or provide testing during the healthcare for any patients?
So we don't actually see patients ourselves. So we're at a higher institute, college, educational institute. So what we do is we do awareness days. We've done it on breast cancer. We do it on cervical cancer, where we go around and make them aware of what we have. The only contact that we do have is where students go out to their clinical placements and preceptorships. And we do have like a relationship with these external entities, and we could look into further where we could do awareness where our students or we ourselves can go out and give awareness to the public.
So, for example, high school, they don't get any kind of this type of education, like about things like
we're at the college. I'm not sure what happens at high school. So, but at the college we do, and especially within health sciences, we do lots of different types of events, awarenesses where we educate, because we have different divisions. We have business, we have engineering, and we have males and females. So we do different days where we do big events and we educate and give awareness. And on those days, we also invite people from external. So, for example, we've got different hospitals here in the UAE, different representatives, and they come in and also do that. We've had breast cancer events where we've had Mediclinic and different hospitals here around the UAE come in, do free mammography. We've had them free advice, awareness to everyone.
And the UAE healthcare, does this provide screening for the female?
Yes, it does here in the UAE. Yes, it does. It's just, I think it's a barrier where the students, I think these young ladies coming from an Emirati background or let's say an Arab background, where they find it not as, then it's like a barrier. And I've read around where there's been different studies similar to this that has been done around the Gulf region, where they've seen similar cultural barriers. So what we're trying to do is, and what we're looking into to try and get rid of that barrier, trying to make sure that they understand that it's okay and it's kind of like a life-saving process.
Thank you very much. Sorry, can you hear me?
Sorry, does your health system also offers vaccines for prevention of cervical cancer?
So here in the UAE, the vaccines have come out, the HPV vaccine. Yes, it is offered to children at high school. So it has come out and it is offered to high school children here within the UAE. As far as I'm aware, it's free for local Emiratis, yes.
Yes, I was about to ask the same question about the vaccine, but I have another question about are the clinicians here recommend the pap smear for the young ladies? or it's up to the patient to ask?
I have no, I wouldn't, because I don't really directly work with them. I work within a higher education, but I do know that it is kind of, it would be recommended here within the UAE for students who, or let's say the females that are married and up and beyond.
For your time. I noticed in one of your survey questions, you asked whether or not the participants believe that a text message reminder for specifically married women. I was
Yes.
wondering if there was a reason why the question was directed for married women as opposed to all women over that certain age group.
Because of the group that we're actually targeting, mostly the majority, as you saw at the beginning, we saw that they're mostly Emiratis. And we are in an institute where the majority, I would say over 90% are Emiratis. So therefore, we went and asked them for married women due to cultural reasons.
Sorry, can you hear me? The question from online audience.
What is the percentage of HPV non-associated cervical cancer? HPV non-associated. Do you have any data? Or?
No, we don't, no.
Okay, and another short question. Why is the prevalence so huge between the countries in the Gulf? Do you have any, you present this in the introduction?
Yes, we, because we're from an educational institute, that's not really part of us, but I would say that it's just maybe to do with the screening methods across, maybe it's to do with HPV prevalences within the countries.
Yeah, regarding this question of what the percentage of non-HPV cervical cancer, according to the recent studies, I think it's 1% or even less. Cervical cancers are related to HPV infection. So I think it's more important to educate.
Definitely.
And how to diagnose.
Just to follow on with that, so we did have another study where we looked into their perception towards taking the HPV vaccine, whether they've taken it or not. So that's another part. I have another part study. So we have actually gone into that as well.
So,
Thank you.
Can you?
Ihr. Guck, ob das. Okay. Hi. Hi. Heb ik zeker kan. Left, right. This. Okay. That's okay. Sure. It's great. Yeah. Closer, but trainings that. Yes. Yes. Sorry. Sorry.
Yeah.
There are.
Yeah. False. Fifteen, 20.
Which one you want me to delete?
The number 15 and the number 20. 20 have two parts.
Number 15?
15 and number 20.
Okay.
It's good.
So these two, right?
These two, right? Yeah.
Which one?
These two are the old version with first part and second.
These two I need to delete.
These two have to
Delete?
be deleted. Yeah. Or different. Then
Now you can change.
Thank you very much. So, and then just take it out.
Perfect.
Да. And my stairs. Press to this. Should rest. That's it. Okay. Just keep this. Okay. Öyle. Birini çektik, bu yan taraftan. Yes.
No. How are you? Thank you. And you? Where from? I am from. So I. Yeah. Oh, where from? I can be thanks.
That's just. And drinks. First, he was very vicious. And I can't slice it. They one other. So that's not. I can see I is. The same, yeah, how do you stop? Right. Okay, I don't think it's done. Yeah.
Okay, we will continue. Yeah, our next, Dr. Lewis Hassel from University of Oklahoma, and we will talk about education using digital pathology. Thank you, Dr. Lewis.
Good morning, everyone. I'm delighted to be here and appreciate your attention as we talk a little bit about how digital pathology is transforming education in pathology and potentially also a lot of other things. So let's just imagine that you're here in Dubai attending this meeting, and your grandma, your great grandma, your mother, whomever, someone dear to you and important to you is back in your hometown. And that just happens to be far up in the mountains, miles, days away from clinics and tertiary care centers, the sorts of things that may be available where you work. But grandma has a mass, and she saw somebody and they said, oh, I think this is breast cancer. We better do surgery and da 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 da. And suddenly there's a crisis in your family because you don't know what level of care is available to grandma. You don't know if the diagnosis is correct, whether it was done by cytology or histopathology or just an x-ray or, heaven forbid, just a physical exam. And that creates a whole range of dilemmas. And that's one of the problems I'd like to talk with us about today, is this whole issue of equitability of care due to inequities in access to trained expertise. So why am I talking about this? Well, who am I? Let me just give you a brief rundown. I got steered into pathology by my father-in-law, who said I should go train here where he trained at the Mass General. And that led me to some wonderful teachers, including Bob Scully, pictured here, a sort of an icon in the world of female pathology, but also a number of other wonderful experiences. Following my practice there, I ended up working in a private laboratory, very large, busy private laboratory in Maine, Dalchase Diagnostics, for 17 years. And I was very happy there. But then the world changed a little bit, and I moved on to the University of Oklahoma, back from a private practice, fee-for-service setting to an academic setting where I could begin to do more teaching, have more interaction with tertiary referral patients, and so forth. And that was a wonderful experience. And continues to be a wonderful experience because of the kinds of people that it put me in contact with. So one of the things that we were able to do, or began to do, was to take some of my colleagues pictured here and do some traveling and some education. So this was a session we put on in Vietnam in 2012, but we'd done several others previous to that in different areas and enjoyed that tremendously. I really found that I relished the opportunities to interact with international colleagues and mentor them and encourage them in what they were doing. That led ultimately to my wife and I spending 3 years living in Hanoi and working both in the medical field as well as in, we were representing our church while we were there. And we just had a marvelous experience. As you can see from the smiles on our faces, it was, to use an English phrase, it was hog heaven. But most of my work day to day involves dealing with sophisticated cancer patients here at the Stevenson Cancer Center in the University of Oklahoma, as well as looking at ways that we can use digital pathology. And this is my little spotlight from the Digital Pathology Association, whom I thank for helping to support me to attend this meeting. So that's a little backdrop on me and where I come from and some of my experiences. But let's go back to Grandma. Grandma actually is part of a growing tidal wave of cancer throughout the world. It's estimated that the number of new cancer cases will increase almost 50% over what it was in 2015 by the year 2030. And, you know, the sad thing about this is that these cancer cases aren't just happening to fall in the areas where there are NCI cancer centers. These are not just occurring in Oklahoma or in Washington or in California or in Dubai. They are out in the countryside. They are out in Azerbaijan. They're out in the villages in Vietnam. They're in the hamlets in Laos and in other places where, guess what? There aren't a sufficient number of either pathologists to make the diagnosis or qualified people to take care of them. And that's illustrated in this wonderful map here that shows you that, you know, if you happen to be the one who lives in one of these red or orange countries, there's an excellent chance that the quality of care that you receive, or if you receive any care at all, is going to be insufficient. And if we look particularly at Africa, this problem is even more acute because when we look at the number of trainees who are on that pathway to become qualified as pathologists, to be able to make the diagnosis so that you can get the right therapy, well, these numbers in each of these countries are the number of trainees. And if you project those number of trainees forward, it's going to take literally 400 years before you will meet the demand for diagnostics of cancer. It's broken. Our system of training and providing care is not going to be equal to this path. So how do we do this? We have to find ways to accelerate competency and increase the numbers of people who can become competent to train, to diagnose, to treat the patients who are coming not just with cancer, but with heart disease, with genetic diseases, and other sorts of things along the way. Now, conventionally, we've had a 2-year, 3-year, 4-year, 5-year, whatever regimen of time-based training that allowed people to accomplish their goal of becoming a pathologist or becoming a trained oncologist or whatever it was. But there's really nothing magical about that time-based training. And so gradually in the US, we have shifted from time-based training, although that's still a very regimented part of it, to looking more at a competency-based pathway. We want you to attain these competencies in these particular areas and domains in medical care for you to be able to then go forward and take care of patients. The other part of the problem here is that with regards to pathology, it's very much like giving someone a set of puzzle pieces and say, okay, go put this together. And we don't give them any sort of big picture of what it is they're trying to put together. We just give them one puzzle piece a day or 10 puzzle pieces a day and say, okay, go fit this into the picture. And in their brains, it takes a long time to do this. So it's very natural that it takes a long time for this to happen. But my contention is that that both of these are the wrong paradigm, that there are tools now available because of digital pathology that will allow us to do things differently. So when we ask the question, how do we make pathology education more efficient and more available? Well, digital pathology is central to that. And how do we get more pathologists faster? Well, digital pathology is central to that question also. And so let me explain why I think this is so. So this work grew out of the Digital Pathology Association Education Committee, of which I'm the co-chair, and resulted in this wonderful review article, Pathology Education Powered by Virtual and Digital Transformation, where we are now and where we think we can be in the future. And this was no small endeavor, because if you've ever tried to write a paper with 20 co-authors, it's an enormous task. But if you look and if you know some of the people behind the faces here, you'll recognize that these are people of no small expertise and no small talent. And pulling together their intellectual contributions to this really did result in a truly groundbreaking and enlightening experience to see what was possible. So let's just speak here about the two main domains in pathology. Anatomic pathology, or AP. What happens when we go digital with that? Can we accelerate learning in AP? Well, there are a number of things that we've already seen that are being done. that have helped to foster this. There are digital slide box courses. These are often in medical school. There are tutorials or other conferences that are presented virtually and live using digital pathology. And these have great acceptance and great advantage. Additionally, there are publications, both journals, atlases, and texts that now begin to use digital pathology and begin to scratch the surface of the potential there. And then you can also use digital slide sets to assess competency. I mean, these are readily available and you can standardize those very easily. The US board examinations in pathology have, for the past 20 years, have been using digital slides to assess competency. And all of these allow people to do a number of things they couldn't do before. They can study in small snatches of time, in little micro study sessions. They help them to create mental frameworks by seeing a variety of things in a particular domain, so they can see the spectrum of the disease rather than just one case example today and another one 2 weeks from now and another one next month and so forth. And it allows them to compare and contrast real time, to do pre and post evaluation study. So those are great advances that digital pathology makes possible. But what about clinical pathology? Well, many of these things also can be transposed to a virtual or digital environment. Use such things as the training in genomics, TRIG, and the informatics, University of Pathology Informatics and Lab Management University. These are all used virtual training techniques to enhance abilities in this regard. Additionally, hematology, very morphologic, very amenable to digital training tools. Likewise, urine sediment and other sorts of things can be used in this manner to enhance and accelerate training. Now, one of the reasons this is possible is that it is both more efficient for the teacher as well as for the learner. So for educators, I do this once, and hey, I've reached a vast audience, not just the 2 students that are in front of me today. I can have it be guided, tiered, progressive education from less complex to more complex, to less sophisticated to more sophisticated. I can give the learners responsibility. I can give them assignments to then identify, to do the sorts of interactions with the materials that are going to make them learn faster and better. And I don't have to go back and undo things. I can update things as we go. For the learners, well, you get very curated, high quality content. I can look at a course from the people from MD Anderson, for example, and see their take on particular cases rather than having to rely on the local guy who maybe is 25 years out of date or whatever in his training. Additionally, you can dissect that learning down into little small chunks, little chunked learning environment. And that doesn't therefore overload you with too much too soon. We mentioned pre and post learning review, the compare and contrast. And the great thing is, I can do this whether I'm at the bus stop, whether I'm in my home, whether I'm in the university, whether I'm someplace else. So it's available anytime, anywhere. I'm ready to learn. And as Buddha once said, when the student is ready, the instructor will appear. And this is a great example of that. So here's one way that you can do once and teach many. There are many YouTube channels and other outlets that utilize or present pathology materials. I have my own channel, but these are 2 of the more preeminent ones, one in AP, Jared Gardner, one in CP, the blood bank guy, which present authoritative, reliable materials, very comprehensive and so forth. And so when I have a student who comes to me and says, well, I don't quite understand the cervical dysplasia matter, I say, well, have you seen my video? Here's where you go. There are digital slides. You can study this, then come back and ask me, we can refine that. So I can give them that kind of assignment, and they grow from that as well. In addition, there's just a whole ton of things out there on the social media side of things, whether it's through Facebook, whether it's through Pathcast, whether it's through YouTube or Kiko or Twitter, that make available just this avalanche of wonderful material for learning. Now, the problem with this is that it's not always organized. It's kind of hit and miss. It's kind of like that puzzle again, without that comprehensive organization. And then there's ongoing virtual content. So Patholist, for example, provides ongoing training opportunities that are available to people that will happen virtually and so forth. So it can update you about that sort of thing. Pathcast is one example, and the DAPA Grand Rounds is another example, which is coming up on Monday, if any of you are interested in that. And I'll just point out that membership in the DPA is complimentary to those living in low and middle income countries. And you can therefore get all the access through the Digital Pathology Association, including these DAPA Grand Rounds. And this Monday is pediatric pathology. And the reason this works is because we've just been through a pandemic and everybody was learning virtually. Everybody was collaborating online. Everybody was using digital. And so today's learners, they can survive that. They have learned to thrive in that environment. And they're developing their self-directed teams and so forth. They have this concept that is different than what I grew up with, which was, what we call the sage on the stage, where you're sitting there, I'm the sage, this is the conventional model. But today's learning is very different from that. Now, when you think about the comparison between conventional and digital training, there are a couple of immediate examples that come to mind. So in my program, the residents might see in their personal management of cases, they might see 10 ovarian cancers and maybe 10 benign ovarian tumors in the course of the cases they personally handle. Now they'll see other slides, but in terms of what they personally handle, that's about it. But if I were to do that virtually, I could easily show them 50 or 100 examples of ovarian tumors and expose them to a much broader spectrum of disease and therefore enhance their ability to define parameters and make a more accurate diagnosis. And that's true all the way down the line at every organ system. You just can't, in a 2 or 3 year program, give pathology trainees enough examples to fully define and to fully expand the scope of disease that they may encounter in real life. So with digital, on the other hand, you can't. You can give them 10 examples right up the front. Here's the spectrum of disease. And so their likelihood of making errors goes down as they understand that spectrum of disease. And any annotations that get put on there by the faculty member can be used and reused. They can look at them again and again. They have the opportunity to connect with other learners who may be interacting over the same slides. And they're able to retain access to those materials. The teaching set is not locked up in my file cabinet. It's available widely and openly. And there are other things that you can do with this as well to enhance learning, such as field tracking and so forth. So here's one example that I'll just sort of explain anecdotally. So early on, I said, my trainees don't understand colon polyps. They've been in this program for a year, and they're still mistaking adenomatous polyps from serrated adenomas and so forth. So let's put together a basic tutorial. So we did that. We gathered digital slide examples of each of the different types of basic GI polyps, and we put them together in this training video with digital slide examples, some exposition of what each of the categories were, and then recorded it on video, as well as made the digital slides themselves available to the trainees. The results were phenomenal. I had residents who had watched this, had been on the service 2 weeks, and who were already scoring much higher than previous trainees with a normal presentation were doing at 1 year or even a year and a half. They were getting 85, 95% of the cases correct right off the bat because they had seen the categories, they had seen examples, they had a mental picture of the spectrum of disease, and they were therefore able to apply that more readily in life, day-to-day work. Now, additionally, once I made this annotation on the digital slide, you can see the annotations here on the right side. Those can very easily explain. This is low-grade dysplasia at Barrett's. This is high-grade dysplasia. This is intramucosal carcinoma. And so any of those annotations can then help an individual slide to become even more powerful as a teaching tool. So how are we going to teach more trainees? Well, I think we need to, quote, open the door. And OPEN is an acronym that stands for the Open Pathology Education Network. And this is designed to address the shortage of number of pathologists worldwide and the quality of pathologists worldwide. So how are we going to do this? Well, our mission is to improve healthcare, improve human health through access to quality diagnostic pathology and lab services. You can't cure a disease if you haven't made an accurate diagnosis. So you've got to go through the pathologist, you've got to go through the laboratory. In order to get more pathologists, you've got to lower the barriers, the cost, the time, the expense, and so forth. And you've got to enrich the resources that are available to the people who are already out there doing the work. So that's our goal, is to lower the barrier and to enrich the resources that are available to all pathologists, not by recreating things, but by organizing things. And this rests on the use of digital pathology tools. Those become critical to allowing people to learn anywhere the high quality of care that's possible at no added cost. So that's the biggest barrier: cost, distance, time. Those are things that this can reduce. But a lot of times it's like all those digital materials are like these ropes just kind of sitting all jumbled up, and you don't know which rope to pick up first or which to go where. So one of the goals of OPEN is to curate the existing materials and organize them into pathways, modules, and organ system topics and sequential learning experiences that allow trainees to take that next step up in their competency, to improve in their competency in a given domain. Because it's kind of like a maze, and if you don't have these little high points to see where the maze is going, you may get lost. And so OPEN will provide that perspective in terms of how you follow this pathway to get there. We're using web source materials that are organized progressively and may include digital slide cases and mentoring sessions, which are live to go along with that, which are kind of the time where you step above the maze, along with assessments of progress and competency. So we want to truly help people to feel and to become more competent. So this is designed at two audiences: those who are in established settings, primarily in the developing world. They'll have enriched resources available. They'll have access to materials that may not be available locally. They'll have this will be a resource for their educators, for their faculty, and will allow them to refine their skills and enhance it. For those who are in a no training program opportunity, we hope to provide ground zero to basic level of competency training. That's an ambitious goal. We hope to also be able to provide some subspecialty training or fellowship type training for advanced individuals, and thus enable these people to provide at least some level of care rather than no care. You would be amazed at how many surgical specimens in the world never see a pathologist. They just get thrown away because there's no service available. Well, we can train people who can do something with that, and that will be better than throwing it away. And also, we want to then provide and help these people develop a network, because we all know that my brain has a different set of understanding than yours, and we do much better when we are a team. Pathology is a team sport. We can't just be solos. This is not singles in tennis. This is soccer. We need a whole team around us. So here's our or pilot project proof of concept with the International Gynecologic Cancer Society, which has virtual. Okay, I go faster. Okay, so with the IGCS, who has virtual training in GYN oncology, we conducted a training session entirely virtually for their pathologists and trainees over a one-year period. We were able to take them from a 60% performance on our pre-test digital slide materials to over 95% on the post-test. And these were complex GYN cases. These were not just, proliferative endometria. And that has been so successful in terms of increasing their confidence and their quality in their program that ICGS wants to partner with us to take this to more places, which we have begun to do in Africa. So this is aimed at providing training at that critical nexus. We know this isn't the total solution to healthcare access issues. There's a lot of other pieces of the problem. But we think if we work on this one centrally, that will drive and draw more resources into these other areas. So to kind of conclude, this is not a one-year project. This is not a 6-month project or a one-person project. This is truly a consortium of effort, and we need more volunteers. We need more support. We need more funding and ideas as to how to make this work in your location. We also need people who want to pull this in to be one of the solutions in your environment. So that can be also very, very important. So we need organizational, we need individual volunteers, we need people to help do the work to create the program. We have a very robust platform for deploying this, as we've indicated, for the GYN modules. But if you're interested in volunteering and helping, see me, come talk to me and let's see what we can do. Thank you very much, and I'm open to questions.
Thank you. Questions?
That's great presentations. So one of the things, for example, right now, like in the States, we have that, multiple scans, and right now, like after 5 years or 7 years, kind of become outdated. The idea maybe we can reach out to all these institutions instead of, just, they can like give those scanners for the outreach. So we can, for example, prepare or have a link so they can upload one slide, for education, or we can give a diagnosis for just the outreach.
Yeah, that whole question of helping more places become digital is a complex issue. I didn't go into that issue, but because there's all the other IT and so forth, bandwidth sorts of issues around there. But I think ultimately that's where we want to go, so that there can be a flattened training or sharing field for consultation, for education, and all these sorts of things.
This is an excellent presentation. I really thank you for this, and I'm so happy. Doctor, my question is, for pathologists from, developing world, can they, for example, if they get confusion with a slide or something, can they upload it for conference on it,
Yeah, so good question. So with our courses and modules, we try to have live mentoring sessions that go in companion with those. So the GYN pathology situations, we have a monthly, each group has a monthly session, and it's interactive. The mentees present cases and the mentors present cases, and there's exchange in that manner. But in addition to those formal sessions, once you become friends with people, it's very easy to share cases. You can either take fixed photos or you can upload a slide, and people send me slides, and if I know it, if it's a GI case or GYN or whatever, I can help with it. But if it's a head and neck case or a kidney case or something like that, I'm going to show it to my colleagues. And so thus you get this broad network of helpers on these challenging cases, which is what we need. That's how we create this team, and we unify our pathology community to become a more potent global community.
Any other question?
I have a comment rather than a question. I'm from the University of Chicago. My name is Slash Malcolm, and we have been experiencing shortage in pathology trainees almost worldwide. So one of our efforts is to increase awareness among medical students about pathology training. APC, American Pathology Chairs, is now creating a curriculum. Currently, it's targeting clinical pathology, and that curriculum is part of digital pathology, and that's easily adoptable by medical schools in the U.S. And we plan also on marketing that among medical schools worldwide as well. So just wanted to make you aware of that.
Yeah, the APC is one of those organizations we really want to pull into this effort, because I think we don't want to be competitive. We don't want to say we're here to upset your apple cart, but we rather would collaborate with you so that we can solve this problem together, because we are all stakeholders in this stack. As we learned from COVID, when there's a pandemic in one area or a disease in one area, it doesn't just stay there. It affects all of us. And this cancer situation and so forth, it's going to affect all of us, whether we like it or not. So we have to be proactive in approaching this. Great comment. Thank you.
Dr. Asli? Okay, our next speaker is Dr. Nasiba Mordan from Shiraz University of Medical Science, and with the presentation of the title of Prevalence of BRAF V600E mutation in the Iranian patient with hair cell leukemia, a retrospective study.
Hello, everybody. I'm very honored to be here today, although it's a little bit challenging to present my humble poster after the great speech of Dr. Hassel.
This is your presentation, right?
Yeah.
Okay, thank you.
Okay, so my presentation is about the prevalence of BRAF V600E mutation among Iranian hairy cell leukemic patients and the association that it has with patients' characteristics. So, as you all know, hairy cell leukemia is a rare but slow-growing hematological malignancy that consists about 2% of all leukemias, and it's characterized by excessive B cell proliferation in the bone marrow, and also it's characterized hairy cell appearance under the light microscope. The patient usually present with vague symptoms like non-specific symptoms like fatigue, weakness, and their lab work also shows splenomegaly and pancytopenia. So the role of gene mutation and specifically the BRAF protein was elucidated by Dr. Hayachi and his colleagues in 2011 in Italy. BRAF protein is a part of MAP kinase cascade, which is a critical signaling pathway for regulating intracellular functions like cell proliferation, differentiation, and also apoptosis. And there have been 43 distinct mutations detected in this gene, but the most common one, here you can see the MAP kinase cascade, but the most common one is V600E mutation, which is a point mutation that alters amino acid valine to glutamate, and this change will lead to uncontrolled cell proliferation in the bone marrow. This mutation has been detected before in other malignancies, for example, colorectal cancer, non-small cell lung cancer, melanoma, and also papillary thyroid carcinoma. So in total, overall, there has been a prevalence of 97% of all patients investigated for this mutation, but there has been a disparity between different countries and different regions. For example, the English and Italian studies showed 100% frequency, but the Indian and Australian studies showed 79 and 89%. So because of this variation in different regions, and also because of the role of this gene in targeted therapy of patients, we aim to conduct a research and to evaluate the frequency of this gene mutation in our own country, in Iran. And up to then that we started our journey for this research, no other Middle Eastern or West Asian country had done this, so we thought it would be helpful. For our study, we included referred patients, eligible referred patients from who were referred to Shiraz Oncological Hospital, which is like a referral center for the southern Iran, and they were all confirmed for BRAF gene for hairy cell leukemia by means of morphological and also immunophenotypic studies, and also their bone marrow blocks were available for genetic evaluation. So in the span of 3 years, we could find 20 patients that were eligible for our study. Okay, about the methodology, we use ARMS PCR, which is a useful method, as you know, for detecting point mutation. And we used 4 primers for both wild type and also mutant gene in each PCR tube. And at the end, we analyzed the results by 2.5% agar-Rozier electrophoresis and visualized the products and the results under the UV light. Here you can see the primers, for the 4 primers that we included in each PCR tube. And here is the final results. You can see the ladder and the control band and the wild type and also the mutant. Our study population will consist of 19 male and also just 1 female, and 17 out of 20 patients were positive actually for the BRAF gene mutation. It makes 85% frequency in our population. Then we compared the characteristics of patients, I mean demographic characteristics like age and the phenotypic profile. And the only significant difference that we found was the age. The patient with positive BRAF gene mutation were significantly younger, about 20 years younger than the wild type ones. So in conclusion, and to conclude my discussions, our study confirms and the previous studies about the prevalence of BRAF gene mutation in hairy cell leukemic patients and suggests the diagnostic role of this gene mutation in patients with hairy cell leukemia. Thank you for your time and your attention. And
So some of these mutations have led to proposals to use BRAF inhibitors as a therapeutic option in some of these types of cancers. Has that been attempted in hairy cell leukemia, or is that under consideration, or are these even available in Iran?
Sorry, in Iran, because of the sanctions and also because of the recent financial problems, we can't actually use the targeted therapy. But when we were conducting the research, the sanctions weren't done and we hope for establishing a system for checking BRAF mutation. At least we could recommend patients who had the wild type ones, which are more aggressive and more resistant to the therapy, to have a chance to at least get their proper treatment in another country. So yeah, that it was our primary intent, but at the end, yeah, we couldn't do as we thought.
Any other question? Okay, thank you.
Thank you.
Move on. The next speaker is Dr. Mustafa Yusuf, the Director of Digital Pathology at Michigan Medicine. The title Tips for Using Quantitative Image Analysis in Breast Pathology Practice.
Hi everyone, thanks for inviting me. My name is Mustafa Yusuf. I am a pathologist, women's health pathologist. I'm my subspecialty breast and GYN, and also informatics, pathology informatics. And I'm also an assistant professor at Michigan Medicine and director of digital pathology at Michigan Medicine. So today we're going to speak about the tips of using quantitative image analysis and mainly in the breast. And the idea is to help you to use quantitative image analysis for breast. So I'm going to ask one question. How many pathologists here in the audience? If you can raise your hand. Okay, great. And if you practice breast pathology? Okay, great. So I have no disclosure. So let's go over the background. So in my opinion, image analysis is really good case or a simple machine learning algorithm that you can use to build your business use case for digital pathology if your institution moving into fully digital. It's one step for precision medicine, for more precision diagnostics, and also really become more close to clinical pathology in terms of, move from qualitative into quantitative science. And by not just saying yes, positive or negative, but for example, for HER2, you can say 0, 1 plus, 2 plus, 3 plus, and you can even right now you can use Levy Jennings, guidelines and then the curve to have your results. And as I said, right now most widely used for breast algorithm. And the most recent 2016 CAP survey shows that around 22% really enrolled in quantitative image analysis for breast biomarkers. And I'm sure right now this percentage increased. So a simple way about what is the image analysis tool. So there are two kind of platform for image analysis. There's a standalone one that you can just plug it in and you can deploy it and you can have your results for, especially for the breast biomarkers. And you have the integrated one that in case if you have what's called PACS or Picture Archiving Communication System that's integrated with your system and you can deploy it and you have your image analysis on. Recently, this platform really moved from an image analysis into whole image analysis by making the analysis on the entire slide instead of only that area of interest. But that will come really with really more sophisticated or deep learning algorithm to make that result for quantitative image analysis. So simple way of image analysis. So usually, to classify that object, take out that object, and then segment it. And then for feature extraction, let's focus on the HER2. Like, for example, what is the intensity of that membrane? And then what is the cutoff for that intensity for the HER2? And then you're going to quantify that intensity and then the threshold between 0, 1 plus, 2 plus, and 3 plus. In terms of histopathology, then you're going to have, nuclear staining, membrane like ER and PR, membrane staining, HER2, some cytoplasmic staining like CD8, and then sometimes become really more complicated, for example, like PDL1. So there are multiple processes you really need to think about when terms for if you want to have a quantitative image analysis solution at your department. First of all, what type of antibody that you use at your institution? IHC stain. Is it FDA clear? The next one, what type of scanner that you have at your institution? And whether that image analysis solution that I mentioned in the beginning, the standalone, or you have the PAC system, can work with that scanner. Or if that scanner really can work with the profile that the scanner produce for that image. And whether that image analysis algorithm can work on different antibody other than the FDA cleared one or the CE marker. You also need to have QC, QA to make sure that if there's any shift, any updates in your quantitative image analysis solution, make sure that, for example, your IT team, if they moved any patch or any update in the system or change in the ICC profile of your scanner, that will not mess up with your algorithm. So in case of something happened, then you need to update that ICC profile and upgrade your system for the algorithm. Another thing for reporting. In the States, anytime that we use quantitative image analysis, we put in the report that this report being used semi-quantitative or quantitative image analysis. And also in the state, we bill for quantitative image analysis. So even there is a CPT code in the state for billing for quantitative image analysis. So all these things, if you want to build quantitative image analysis, you really need to think about it. What is the benefits? Why do you need to use a quantitative image analysis? So it has more precise, as I said, quantitative measurements. Okay, every time that you deploy it, every time that you run it, will give you the same results. Standardization. I'll give you one more example. Right, for example, Michigan Medicine, we are self-specialized, and we have 10 pathologists who sign up breast pathology. Imagine that each pathologist can look at the biomarkers and then give their interpretation. While if you have a standardized tool that really have more standardized every time, precise, accurate results every single time for that biomarker. Automation. This is really tricky for automation. For example, unless that you really use a digital, like you sign out fully digital, then automation then really might help you. Sometimes, pathologists might be really reluctant and they will say, I can literally look at the slide and make my interpretation with a few seconds. That's true. If the pathologist that's really, expert. But if you are generalized, right, and if you don't practice breast pathology every single day, then you might have some discrepancy now and then between, especially right now, we have the low HER2 for the IHC. But for the digital pathology, if you sign out really digitally, then you don't need to have, for example, at Michigan Medicine, we have a text that you have to annotate, and then they have to do the analysis on data. So it's kind of more time consuming, but if you have a fully digital platform, then you just deploy it and you have your results. And again, for recommendation that you really, for example, in the States, we really have to follow up the ESCO-CAP guidelines. What is the cutoff and how many cells? What is the intensity to run your quantitative image analysis? And whether you are using an FDA cleared or CE marked algorithm versus a lab developed test or LDT test. I'm just putting here, this is the most recent publication about the breast biomarkers of ER, PR, HER2, Ki67, as well as the P53 algorithms that is FDA cleared, and you can get benefit of it. But unfortunately, really right now, most FDA cleared algorithm right now is kind of outdated. So you have to make sure of the cutoff. You have to make sure of the CAP guidelines that they really follow. Otherwise, you're going to have kind of really different results from the way that you are interpret your report right now. I'm going to just also regarding the CAP. So the CAP gave multiple recommendations, I think 11 recommendations of how to validate your algorithm if you have your quantitative image analysis at your department. And you can, it's public over there, so you can go and review them. But I'm just going to focus on a couple of things right now. So most important thing, you have to work with your vendor and ask them the following questions, like, you know, what is the number of cells? How many area of interest? What is the intensity? What is the cutoff? All these are really, really important to make, you know, the precise and the best algorithm that you can pick. The other thing is whether you are choosing an FDA cleared or lab developed tests. And there is the difference here, like if you are using an FDA cleared, you need to review about 20 positive, 20 negative. For the LDT, you have to double it. And then you have to compare it to a standard. For example, like I'm just gonna focus on the HER2. What is the standard? What's the gold standard? It's the fish, right? So you have to compare it to fish. Or if you have an FDA cleared already in your department that you run for years, you can compare the one that you're using right now to the new LDT test if you are bringing it to the, like if you have a new algorithm, you want to bring it to your department. And then you have to make sure that you are following the concordance and discordance about this. I'm going to just go follow about what is the workflow at Michigan Medicine and how do we do it. So in Michigan Medicine, we're doing a quantitative image analysis for more than 8 to 7 years. And right now we are even moved to a newer platform. And in the recent months, also, we are going into a different machine learning algorithm that include not only breast biomarkers, but also quantitative image analysis for Ki-67 for CNS, neuroendocrine for GI, because all these are really important for the pathologists. And right now, like the pathologists have to take, for example, pictures or do manual quantification or semi-quantification for those subspecialties. So first of all, like let's say if you have invasive or in situ carcinoma, the pathologist will order the biomarker for quantitative image analysis and also will annotate the area of interest for the H&E. And they will send the slide as well as to the IHC slide preparation. And then all these slides will go to the technician, and the technician will scan those in the scanner, and then they will do the analysis. And then after the analysis, the report will be generated. The report plus the slide and everything will go to the pathologist. The pathologist still here at Michigan right now reviewing it manually, but with the help of quantitative image analysis results, and then finally the report will be released. So we are using the Ventana Benchmark Ultra, and for the all breast biomarkers. And the reason of using that, because right now we are using FDA cleared algorithm, and that's why we went with Ventana Benchmark Ultra, because that FDA cleared algorithm from Roche really wants only work with the Ventana Benchmark antibody and only with a specific scanner. So this is the old system. As you see here, the technician load the slides, and we do it by batch by batch. So meaning that every time that we get the slides from the stainer, we put it on the scanner, and then we do the analysis. So we don't wait for the entire batch to scan it. Next, as you see here, this is the case management system, and the technician will start reviewing the image analysis and generate the reports. This is just a 20x magnification for the ER IHC. And the idea is you drop all these field of interest, and we follow a standard operation procedure about make a quantitative image analysis about 40, at least 40 area of interest. And then after the analysis on this area of interest, then you will generate all these boxes of all the analysis and the final result for that analysis. This is the new system for the Roche UPath case management system, and it has better image quality using a different type of scanner and also faster analysis and can do the analysis on the entire tissue instead of just dropping the area of interest. So it's really decreased the time consuming right now for do the image analysis and helps a lot our technicians. So we want to make sure that how the quantitative image analysis contributes to our like standard practice. So we conducted this study. It's a retrospective analysis of around 1,400 cases of invasive breast carcinoma. And we compared to the pathologists with or without the quantitative image analysis to see the concordance. So, and we saw really high concordance, about 90% between ER, PR, as well as the HER2. And the discrepancy for those cases really because sometimes the pathologist might not give the annotation for the area of interest for the invasive carcinoma. So sometimes, unfortunately, the technician might annotate the area of interest for the in situ. That's one of the area. Other really pitfalls, for example, if you have low HER2 or low ER, that might sometimes really trick you between what is the stroma, what is the benign duct versus really low positive for the invasive carcinoma. So these are the area that's really sometimes pitfalls, and I'm gonna explain it in the few slides. In a recent clinical trial, it's Destiny Breast 4. So there is an antibody drug conjugate, TXD, that has shown a significant benefit of treatment of metastatic breast cancer. The treatment showed positive results in both hormone positive, hormone negative, include triple negative breast cancer. Unfortunately, this drug has a little bit of potential risk for interstitial lung disease. So patient selection is really important in this matter. But this is a really groundbreaking discovery, was considered practice changes in the treatment of metastatic breast cancer, expanding the patient population that can potentially benefit from it. Not just the HER2 amplified or overexpressed patients, but larger, more diverse patient group. Shortly after that, the FDA swiftly approved the therapy along with its companion diagnostic, the HER2 testing. The companion diagnostic is essentially an extension of the indication for our the 4B5 Herceptin testing. They utilize, I believe, the Benchmark Ultra platform for the HER2 testing along with the Ventana pathway assay. So I just want to have a few words about what is HER2. So HER2 is HER2 low. It's incomplete membrane staining that is faint or barely perceptible, and it's more than 10% of tumor cells, that is IHC1+. Plus also, any weak to moderate complete membrane staining in more than 10% of tumor cells, which is IHC2, but the reflex of either ISH or FISH negative, it's also HER2 low. So with this definition, comes really, of course, the interpretational issue, which is, there are multiple papers shows you that there is like different between the 0, and there is no agreement between 0 and 1+. And mostly it's the significant inconsistency in distinguishing between 0 and 1+. And you see here about there is 15 to 26% agreement rate, right? And the recent CAP survey shows you that 19% cases have less than 70% concordance of IC score 0 versus 1+. And one of the problem also is there is absence of the reference standard increases the risk of false positive or false negative HER2 low identification. So if you open the package for this Ventana benchmark, they really did a great job for the reproducibility, and they used 3 pathologists, score each case twice, and schedule at least 2 weeks apart between these reads. And this helps, for the, for bias issues. And as I said, they showed great reproducibility for most of the cases, except the following. When it comes to the borderline cases about 0 and 1+ on the 10% threshold, they really shows poor reproducibility. And they recommend the following. They say every time that you have a 10% this threshold, they recommend that a second read pathologist have to review it. And unfortunately, right now we are using it at Michigan Medicine also. Every time you have this, you have to use a second read pathologist. So in order to address this issue, so we attempted another study. And the aim of this study is compare quantitative image analysis with pathologist scoring for low HER2. The method was a retrospective of 157 invasive breast carcinoma. The quantitative image analysis system scored these HER2 IC slides as HER2 negative or 1+. And then we also have a ground truth by 2 expert breast pathologists. And then we exposed to this result to the next 4 pathologists, and these 4 pathologists without access to the quantitative image analysis. And then, as you see, it shows really high agreement with the ground truth for the pathologists with access to quantitative image analysis versus pathologists without access to quantitative image analysis in terms of 0 and 1+. And again, the disagreement for the mainly for those disagreement is really false positive. And the quantitative image analysis about 7%, and pathologists without quantitative image analysis about 11% pathologists assigned HER2 IC score with quantitative image analysis access had the least false positive, about 5% in discordant cases. With 2+ IC interpretation, HER2 FISH was negative in about 86% of those cases. Now I'm just gonna go a few cases that, with or without access for that trial. So here you see 2 out of 4 pathologists without access to quantitative image analysis scored as 1+, while with quantitative image analysis, 4 out of 4 of them quantified as 1+. And this one, the quantitative image analysis really help you to quantify it the right way. Next case is, you see here, 2 out of 4 pathologists reviewed without quantitative image analysis scored as 2+, while with access to quantitative image analysis, 4 out of 4 of them quantified as 1+. And the reflex for the FISH for this one was negative. So this is a true HER2 low. Now I'm just going to go through some slides that how to optimize and you have really optimal results for your breast biomarkers. First, you really need to use an FDA-approved assay, and you have a quality insurance program. Next, you have to have a control on your slide. It's either on the slide, and you have the verification of negative, positive controls, mid-range if that's possible, and normal tissue. That's really help you to make some comparison between the HER2 intensity versus the control. Next, when it comes to magnification issue right now, you really can't really make diagnosis on 3+ versus negative. It's so easy, on low magnification. However, studies shows that, for this 1+, you might really need to go really on higher power, for example, 20 or 40x, in order to find those area of interest, and you can make the quantification. For the algorithms that can do the analysis without even choose the area of interest, that's fine. That's really because it can detect the invasive from stroma, from in situ, and do the analysis. But if you have an algorithm that you have to have the area of interest choose, then that's a problem. Then you really need to go higher power to choose your analysis. Then annotation. It's really important for a pathologist. If you have an area of interest you want to annotate, you make sure that you annotate the area of interest for the invasive versus not including the in situ. And this is an example, and show you that if you annotate the area of interest of invasive, and you have to exclude the area of in situ carcinoma, while if you include this, then it will bump into 2+, for example. Another 5 minutes. Yeah, almost done. Thank you. So another example here, when you see the membranous artifact. So it's the intercellular membrane positivity. That's the most important thing. So here, like for example, micropapillary carcinoma, you have the U shapes, or for the positivity, that's a 3+. Problem however, for the tubular carcinoma, sometimes you have this membranous faint staining. So you have to be careful of this pitfall and not call this one as like 1+ or 2+, because this should be negative. This is membranous staining, shouldn't basement membrane staining, and shouldn't be included. Another artifact, if you have only cytoplasmic staining without membranous, make sure that you not include this area, because this is really, really important. If you have membranes and cytoplasmic, that's okay. And we usually really forward this one to FISH and quantify it. Next step, if you ink your core or ink your resection, that's also sometimes might trick the algorithm, and make sure that you don't do the analysis. For example, here is like, this is 1+, but if you do the analysis on the area that's really picked a lot of ink, then this is gonna bump it to 2+, which is another pitfall. So finally, in conclusion, quantitative image analysis is really a great tool that help you and support pathologists for centralization, and can help and improve for the breast biomarker standardization, especially for the low HER2. And to avoid pitfalls, pathologists really need to oversight of the representative regions, and selected of those regions is really recommended. With that, I'm open to questions.
You for the great talk.
Doctors, thank you for your presentation. I have one question for you. The last time in Azerbaijan, hormone positive cancer, hormone positive breast cancer is low, 67% is low, get more aggressive, give more metastasis to the other organs of the body. What's your forecast about it?
You're talking about the HER2 low? Hormone
Slow person, slow aggressive person.
KIC7? Yeah, so right now there is a recent study about, there's no really specific percentage. They usually right now it was a 20% cutoff for the KIC7 to give, there's a new medication for that one. But right now, I don't think there is any cutoff for the KIC7. So we don't use KIC7, by the way, at all. We don't use it, yeah. Unless the clinician, recommend, I mean, just, they want to, order that one for that specific patient. Yeah.
Thank you so much.
Sorry, may I?
For great presentation. As medical oncologist, I am very interested in the trust good result in HER2 positive. But I have another question. Have you any experience to learn relationship between mammographic images and pathologic results? Have you any?
Yeah, so that's called computer-aided diagnosis. And that's a different area for computer-aided diagnosis. And in order to do that, you have to have a digital image. For example, radiology already from the get-go, you have the digital image, right? Unfortunately for pathology, you still use this slide. So unless that you really digitize your pathology images, then you can apply, for example, right now there's machine learning algorithm, deep learning algorithm that you can, put the radiology plus the digital pathology together to see the correlation or the concordance. One simple example, calcification. How big is the calcification in the imaging versus the histopathology. So you really need to use a digital image to further go to the next step, which is the computer-aided diagnosis. Yes.
What about the CD44 breast cancer? Could be detected in the digital pathology like HER2?
Sorry, what is the marker?
44, CD44.
CD44?
Yes.
So what is it? Is it cytoplasmic nuclear? I'm not familiar with the CD4.
I get it by
stem cell marker? Yeah. Yeah, I mean, if you can do IHC on it, and then you can do the analysis on it, then you can do the quantitative image analysis, but you have to train it. And then when I show the validation, you have to have a full set of, if you never use the quantitative image analysis, then you have to train your algorithm on thousands of cells, thousands of images in order to have a reliable quantitative image analysis, not only of few cases.
Any other questions? Okay, thank you, Dr. Mustafa.
Thank you so much.
Okay. Shall press on. This is what you do. Yes. Our next speaker is Dr. Rosana Vakovikin from Azerbaijan Medical University. Point of Point of ultrasound diagnostic in breast cancer. Yes, so. What?
Desteği verin ben orada. Thank you. Yes.
Yeah. I have a lot of
Yeah, this Thank you. Greetings, my dear colleagues. I am from Azerbaijan. I am a radiologist. I am very proud to be here today. Topic my presentation, key points of ultrasound diagnosis in breast cancer. Breast cancer is considered one of the most prevalent cancers worldwide in women and represents a global health challenge. Early diagnosis is the keystone in the management of breast cancer patients. It is essential to assess the utility of ultrasonography data of malignancy in the diagnosis of breast cancer. The ultrasound signs of breast mass are explained by the histopathological data. The shape and the margins of the mass depend on its histopathological types and its tissue compositions. Key point, all pathological process led to an increase in lobular units of the terminal duct, forming formation that at least at the unital states have either a rounded, oval, or statelet irregular shape. Benign shapes, oval, rounded, display surrounding tissues. Malignant shapes, round, irregular, invade surrounding tissues. Round can be a benign or a malignant shape. The height of the round mass is increased compared to an oval mass. Can be a sign that a mass is starting to not respect the tissue's place. This is macrolobulated margins, large lobulations, more than 2 millimeters, shaped like the cloud. Ultrasound appearance of the medullary carcinoma showing a half ill-defined hypoechoic hypovascular mass with macrolobulated margins, hood-shaped, with posterior acoustic enchainment and with microcalcification. Non-circumscribed, ill-defined or obscured margins. The edges of the tumor are poorly visualized. Transition between tumor and surrounding tissues is busy. Indicates host response of surrounding tissues to tumor desmoplasia. Tumor is invading surrounding tissues. Desmoplasia. Think hypoechoic border around the tumor halo. Indicates tumor is infiltrating the surrounding tissues, is displaying a host response. Should be increased in the measurement of the tumor. Angular edges. Irregular borders, one or more markings of the tumor has sharp corners. Speculated edges, Lines that radiate outward from a tumor, hypoechoic when surrounded by glandular tissues, hypoecholic when surrounded by fat, when spicules are not fully developed and echogenetic halo can be seen around the tumor. Feature most in the ways of tumor invasion in surrounding tissues. Microlobulated, multiple small lobulation, less than 2 millimeters, fingers of invasive tumor. Shadowing, increased attenuation of sound waves with a tumor, results is in dark echoes posterior to a tumor. Breast cancer equal shadowing from high density of tumor. Breast cancer echo extramuscular is heterogeneous, non-evenly distributed echoes within a tumor, multiple echogenicities present calcification. Highly cellular cancers can have more homogeneous echo textures. Vascularity, breast cancer vascularity, blood flow in a mass confirms it is solid. Hypervascular, larger feeding vessels within tumor, aortic pattern of vessels, central vascularity, neoangenesis, malignant tumors grow hair out blood supply to feed hair rapid growth. Heart cirrhosis, cancers compressed internal vessels display a minimal vascularity. High resistance, malignant masses display a high resistance spectral Doppler pattern of flow with a little to no diastolic flow. High pulsality, malignant mass display a higher pulsality pattern with absent of low diastolic flow, steeper shocks and higher velocity flow. Ultrasound appearance of an intracystic papillary carcinoma. A. Ultrasound image showing a homogeneous round mass with macrolobulated margins shown to be an infiltrating papillary carcinoma of microbiopsy. B. Power Doppler ultrasound image showing the presence of rich central vascularization. How to be breast cancer of ultrasound case 1, mass, location, left breast at 16 o'clock, number 1, size 2.7 by 2.2 centimeters, shape irregular, orientation not parallel, margins angular, echo pattern, hypoechoic, posterior features, multi-acoustic shadowing, calcification, few in echogenesis present, associated features known. Strain elastography, hypoechoic area and surrounding tissues are hot. How to report breast cancer on ultrasound case 2? This is mass, location, right breast at 11 o'clock, number 1, size 3.4 by 2.8 centimeters, shape irregular, orientation not parallel, margins angular and macrolobulated, echo pattern mostly hyperechoic, excuse me, posterior features, acoustic shadowing, calcification, so echogenesis present, vascularization peripherally vascular. How to report breast cancer of ultrasound case 3? Mass location, left breast at 2 o'clock, number 1, size 2.3 by 2.9 centimeters, shape irregular, orientation not parallel, margins speculated, angular, echo pattern hypoechoic, posterior features, acoustic shadowing, calcification, few echogenetic present, surrounding tissues, hypoechoic halo. With mostly hypoechoic irregular shape, uncircumscribed border, angular and indistinct, small calcification on the mammography also, no posterior shadowing on enhancement. With lymph node invasion, round shape, thickening of the hypoechoic cortex, lobulation of the cortex, central fatty ileum loss, irregular margins of lymph node, peripheral blood flow pattern. And lymph nodes, additional information, this is strain elastography, pathological change, lymph nodes, heart tissue signals. With hypoechoic mass with irregular shape, indistinct border, hypoechoic halo, posterior acoustic shadowing, and not parallel to skin. Very small mixed echogenicity mass, irregular shape, indistinct border, hyperechoic halo, not parallel to skin. This is digital mammography showed the solid mass with irregular shape, indistinct and angular margins. On the US exam, boundaries of the lesion, poorly visible mass, were not there with no uniform internal echoes. Histologically relieved invasive ductal carcinoma. Invasive lobular carcinoma. The digital breast tomosynthesis scans show more compressed architectural distortion. Dashed circles compared with the digital mammography images. Difficult to see on ultrasound, speculated margins of MIR. T2 weighted speculated mass, T1 weighted pre-contrast, hyperintense small speculated mass, T2 weighted post-contrast, heterogeneous enriching mass with speculated margins. Subtraction image shows a small enriching speculated mass. This is diagnostic pitfall. Biopsy-proved fibroadenoma. We can make a misdiagnosis based on the patterns of breast cancer in the image. However, if we are careful, we can see the presence of the wind capsula surrounding the tumor and the posterior acoustic shadow due to microcalcification inside the tumor. Another diagnostic pitfall. Small irregular shape, mostly hypoechoic mass with angular margins, without posterior shadowing, not parallel to skin. Biopsy-proved fibrosis tissue. Sometimes we can, interesting images. It's our sweet squirrel. For home, ultrasound cancer patterns, hypoechoic, most common irregular shape, less fragment round of oval, margins indistinct, angular, macrolobulated, speculated, ventricle orientation, frequently posterior shadowing, small calcifications in or outside mass, hypoechoic halo. Results. Ultrasound imaging features of malignancy have a high sensitivity and positive predictive value of for detection of the breast cancer. The specificity of breast ultrasound images features in much lower because of the overlapping features in benign and malignant breast lesions. Breast lesions with angular shape, not syncopated, irregular or speculated margins, hypoechogenicity, tissue distortion, and with lymphadenopathy have the highest likelihood of malignancy despite the low specificity. Ultrasound is highly available, safe and affordable imaging modality with high diagnostic accuracy for breast cancer. Every diagnosis saves lives. Every dark night has a bright morning. Let's be alert to every patient. Thank you for your attention.
Thank you, Dr. Samuel. This is your certificate. Question then Speaker is Dr. Mona Huna, pathologist and laboratory director of Ketone Laboratories, the top driving screening for colorectal cancer.
هدوس بس انتر صح؟ ان شاء الله. Good Good afternoon or good morning. Good morning, everyone. It's a pleasure to be here. And I'm really not sure how I'm going to present with all these beautiful presenters. Like, you raised the bar very high. However, like, I'm coming here to present about something very near and dear to my heart, as really we did save a lot of lives by laboratory screening of colorectal cancer. So it was a Friday evening, and as a dedicated wife, I was in the kitchen preparing some snacks for our evening, relaxing weekend evening. And then my husband phone rang, and his friend said, "Oh, you know what? Your best friend Ali got colon cancer." And it was really, really very surprising and disappointing, as Ali himself was a doctor treating thousands of patients in Egyptian countryside. And he, as a doctor, always supposed to take care of himself. After moments of silence and being shocked, I started to remember my conversation with Ali the year before about how colon cancer screening is really saving lives, and how it is really very simple, and you just give me your poop and I tell you that you are safe for the next year or the next whatever years. So, but Ali was really too lazy to give me his poop to check for his colon cancer screening. And very unfortunately, Ali presented only by vomiting. And this vomiting is one of the very few symptoms for metastatic colon cancer screening. He presented by vomiting because he was obstructive fourth stage colon cancer screening. Sometimes other people may present by only bleeding rectum, diarrhea alternating with constipation, probably iron deficiency anemia, stuff that are vague and not pointing to colorectal cancer. So, am I, is this, yeah. Okay, now I know what to do. All right, so let us start with a brief introduction about colorectal cancer. It's the second leading cause of cancer-related deaths worldwide. And colorectal cancer develops from a precancerous growth of a polyp. And this polyp may take 10 to 15 years to develop into cancer. So we have 10 to 15 years to detect the polyp before the polyp starts to be a cancer, and then to remove the polyp and we don't have cancer. Removing these polyps is the most effective way to prevent the development of colorectal cancer, because it takes approximately 10 years for a small polyp to develop into cancer. Colorectal cancer is attributed to two things, either to both genetics and environmental factors. So colorectal cancer is it's the third cause of death from cancer worldwide. And colorectal cancer is often asymptomatic in the early stages, as we mentioned. Regular screening are essential to catch the disease early and begin treatment. In addition to regular colon cancer screening, exercise, maintaining a healthy diet, healthy weight can reduce the colon cancer prevalence, the risk of colon cancer. My question to the audience is colon cancer preventable? Could we prevent? My question to the audience: could we prevent colon cancer?
Yes.
Yes. And how?
Yes.
Yes. For how many cases we could? 90%. 90%. It is really like, you know, if we do a proper screening for colorectal cancer, maybe we could prevent together with, like, you know, changing the environmental factors. Yes, exactly, exactly. So I am not. So how we? I have a problem. Can you just make it one slide per? Maybe click on this. On this one, probably.
No, this is Zoom.
All right, now I know what I'm gonna do. I use this.
This slide? Yes, this slide, right?
Yeah.
Okay. And I sent that sample, wasn't.
All right. Okay. So as we mentioned, 90% of colorectal cancer and deaths from colon cancer is preventable. Colorectal cancer is often asymptomatic, we mentioned that, and regular screening is the key. In addition to screening, like healthy diet, low-fat diet, high vegetable and fruit diet, exercising could reduce colorectal cancer. So how to reduce it or how to prevent it, as mentioned, eat well-balanced diet, reduce fat consumption, increase consumption of fruits, exercising, and the most important is, it's not the most important, but it is really important, it is don't smoke. So screening for colorectal cancer. Okay, I had the opportunity and the privilege to work into 3 continents and 3 countries in 3 continents. I'm Egyptian, so I worked in Egypt. I'm Canadian, so I worked for the colon cancer prevention program in Canada. And I am also working in Dubai, so I work in UAE. So the story is, like, you know, in Canada, our guidelines is that, like, you know, we screen for colorectal cancer for average risk individuals. And please remember, it's for average risk individuals, because we will speak later about high risk individuals. Every 2 years, we do the fecal immunochemical test, and for FIT positive population, what we do is to send for colonoscopy. In here, in UAE, they started the colon cancer screening in 2013, and generously, they are doing it at the age of 40, and every year, like, you know, they don't have, like in Canada, we do it until 75 years, but like, you know, here they do it whatever the age is. Who are average risk? Can anybody help me with this? Like, who is average risk relation?
Obesity.
Average risk would be like the people who don't have risk, high risk for colorectal cancer. So these are people who are asymptomatic. What? No, I love, like, you know, I really love interactions. So like, go ahead, guys. Like, you know, let us get it done. Right. So that. Exactly. No family history, no ulcerative colitis, no Crohn's disease, no familial hyperpolyposis, like, you know, nothing of the risk factors. So for these people, the best way to screen is just to give, like, to send your patient to the lab and give some poop, and we give them peace of mind. So how about high risk individuals? Yes. Who told that? Thank you. Okay, so the screening starts 10 years before, like, the average risk individuals. And does it do we do it by fecal by stool test, by fecal immunochemical, or do we do it by flexible sigmoidoscopy? Yes. So for these people, for high-risk individuals, the screening is by colonoscopy or flexible sigmoidoscopy. And this applies to individuals with a history of colorectal cancer, adenomatous polyp, familial adenomatous polyposis, Lynch syndrome, Creutzfeldt-Jaeger syndrome, inflammatory colitis, ulcerative colitis, or Crohn's disease, or a close relative with colorectal cancer diagnosed before the age of 60. Okay, telling you the truth, like, Ali's story, 5 minutes?
Things specific. It's not informed. They go early. As example, Lynch syndrome will begin at age 25.
Yes, Doc.
Okay,
Yes.
so specifically.
These are high risk.
Yes, high
Yeah.
risk, but not begin with age 40 is early, most of this patient.
Exactly.
IBD is depends of the time period
Yeah.
of the disease and like so.
Exactly, exactly. Thank you, thank you.
And after bariatric surgery, it's a high risk for colon cancer.
Oh, yes. Okay, for these people, like, and just remembering Ali, my husband, best friend, like, unfortunately, his brother also died from colorectal cancer. So it's sometimes it runs through families. So these people don't send for stool tests. Please just, like, send a refer to colonoscopists or to internist or to whatever to do with to screen with the proper screening. How about symptomatic individuals? So somebody came with iron deficiency, anemia, or sudden weight loss, or diarrhea alternating with constipation, or bleeding the rectum, anemia. Like these symptomatic people, do we screen with fecal immunochemical test, or what do we do? No. Thank you. No, because, like, it would be misleading if like 5% of the fecal immunochemical test could be false negative. So we say, oh, congratulations, you don't have anything, and the guy is in a big problem. So no, thank you. So these people do not screen, just please start investigation, aggressive investigation quickly. So what I am going to speak to you about today is the fecal immunochemical test and fecal occult blood. So occult blood means blood that I can't see under a microscope. It's not a fresh blood. It's a blood occult in this. So for this, there are two tests, and as you can see, like, I am in my 50s, so I saw the first test and and the newer test, and like hopefully very soon we will also adopt the fecal GNA test. So the thing is, like, first it was the guaiacal fecal occult blood test, and this guaiacal was really terrible and headache, because you will come to the patient and say, next 3 years you should not take non-steroidal anti-inflammatory. Next 3 days, I mean, you should not take any meat, no red meat, no pork, no chicken. You should not take more than 250 vitamin C. You should not. These fruits and vegetables you should avoid. And then the patient may cheat or may not cheat, like, and then the test comes positive, and unfortunately it's false positive. And why it is false positive? Because this test targets, give me a second, this test, the guaiacal test, targets the peroxidase enzyme in the heme. So blood is hemoglobin, so there is heme and globulin. For the heme, the guaiacal chemical targets only the peroxidase. So anything has peroxidase would give false positive, and we are in a not good shape. Then comes the fecal immunochemical or the immunochemical fecal occult blood in stools, which we use here in Dubai, to target the globulin and to be very specific to the human globulin. So it uses antibodies to the human globulin, and then this increased its sensitivity and specificity. So I thought, like, I will do some comparison. So with the two type of tests. The principle is this uses the chemical Guayacam model. The other one, the fecal immunochemical, uses the antibodies to detect blood in stool. This targets the heme of the hemoglobin molecule, uses the peroxidase activity. Dietary peroxidase could give false positives. This targets the globulin of the hemoglobin molecule. Preparation, the guaiacal, we spoke that it needs tons of preparation, and no, don't do like this. But for the fecal immunochemical, it is on the doesn't require any preparation. The bad thing also about the guaiacal was, like, you 3 consecutive days, you give stool for 3 consecutive days, which is not convenient to the patient. This is only once. And for sure, the guaiacal is less sensitive and specific rather than the fecal immunochemical, which is more sensitive and specific. So does this mean that the fecal immunochemical is 100% accurate? No. Some polyps don't bleed. So that's why we say frequently do the test every 1 year, because if the polyp didn't bleed today, it could bleed tomorrow. The other thing is that, like, if somebody have bleeding hemorrhoids, or if a lady has her period, this to be taken into consideration when we do the test. Thank you very much.
Thank you, Dr. Mona. Any questions?
I was worried you ask a question I don't know. Thank you, guys.
Thank you. This is Natalia Gorbokon from the Institute of Pathology Center, Hamburg, Eppendorf. The talk entitled Hemoglobin A expression is high specific for tumor derived from the breast, the fetal genital tract, and salivary gland tumors.
Dear ladies and gentlemen, it's a great honor for me to present our work on hemoglobin expression in different types of tumors. Sorry. These are my disclosures. Hemoglobin is a small secretory epithelial protein, and in normal tissue, hemoglobin A expression we can see mostly by the mammary gland, and because of its frequent upregulation in breast cancer, this protein has been proposed as a promising target for therapy in these tumors. The impact of hemoglobin overexpression on breast cancer aggressiveness is disputed, and some studies reporting a tumor promoting, some studies tumor suppressive or no effect. So here on the left side, you can see results of hemoglobin expression studies taken from PubMed, and you can see great discrepancy in data. And on the right side, you can see RNA expression taken from the Human Protein Atlas. And you can see that mostly expression of mammoglobin we see in breast cancers, a little bit also in endometrial cancers, and occasionally in some other type of tumors. Such discrepancy in immunohistochemical expression of mammoglobin can be explained from different factors, for example, different antibody clones, different scoring criteria, or different lab equipment and protocols. So aim of our study was to analyze mammoglobin expression in all tumor types under highly standardized and optimal conditions. And microtissue array suit very good for such purpose. Our tumor tissue microarray consists of 128 types and subtypes of tumors at all more than 60,000 samples. And you can see here our paraffin blocks with microtissue array samples. Also, for this investigation, we had detailed histopathological and molecular data for breast, colon, ovarian, endometrial, stomach, and pancreatic cancer, and also clinical follow-up data for breast cancer. Our strategy of our institute by immunohistochemical study is identify a fully specific antibody by following the recommendations of International Working Group for Antibody Validation. We used at least 2 antibodies on great amount of samples, and also we compare our antibody, then we compare our results, and also we compare our results with other methods, for example, with RNA expression from protein atlas. And also we perform our study on more than 8,000 cancers. So here you can see our normal tissue array, which consists of 76 different normal tissue types at all more than 600 samples. And for normal tissue array, we used 2 antibodies and then compare our results. So this is a principle of comparison of antibodies, and and fully specific antibody, mammoglobin antibody, only considered well all stain structures confirmed by other mammoglobin antibodies. And when we see only distant staining by one mammoglobin antibody, but no by other mammoglobin antibodies, it means cross-reactivity, non-specific binding. So on this slide, you can see that both our antibodies stained breast, endocervix, endometrium, and fallopian tube, and it means specific binding, specific reaction. And by staining with second antibody 304, we also saw quite strong reaction in thyroid gland. And by staining with first antibody, we didn't see this reaction. So it's not specific binding, it's cross reaction. On this slide presents specific staining by using both antibodies in endometrium, fallopian tube, submandibular gland, and also endocervix, a little bit stronger by staining with antibody MSVA. Here on this slide, we can see unspecific staining, unspecific cross-reaction in thyroid gland, in aortic wall, in small intestine, and also in slight cross-reaction in epididymis by comparison to antibodies. So for further investigation of tumor tissue, we choose antibody MSVA as more specific and suitable for such type of investigations. And our microtissue array, tumor microtissue array, consisted of 128 tumor types and subtypes at all more than 60,000 samples, including extended numbers of ovarian cancers, endometrial cancers, breast cancers, and also we had histopathological and clinical data. On this slide, in graphical presented ranking order, you can see results of our investigation. From 128 tumor types and subtypes, 37 categories showed positive expression, and with blue dot is frequency of all type of positivity, and orange spots, it's strongly positivity. And from these 37 types and subtypes of tumors, 32 types were derived only from 4 organs. It was ovarian, breast cancer, endometrium, and also salivary gland. And additional 5 categories showed only occasional staining, mostly weakly occasional staining, and this was medullary thyroid carcinoma, testicular teratome, 1 case of prostate cancer 5+5, and also squamous cell carcinoma of pharynx and skin. And you can see that most positive cases were observed in breast, and it was high differentiated tumor, tubular breast carcinoma, and also lobular carcinoma of breast. On this slide, you can see intense reaction, very intense reaction in near in 100 cells. And here you can see also expression in endometrioid endometrial carcinoma, in breast cancer of no special type, and endometrioid ovarian cancer from different intensity. And for example, in high-grade serous ovarian cancer, in adenoid cystic carcinoma of the salivary gland. So in order to obtain reliable results, we compare different antibodies in all human proteins and select the antibody that stains non-positive tissue but is negative in all other tissue. We stay all our study tissues under the same conditions. At the same time, with the same protocol and reagents, use fresh tissue sections. Let one experienced pathologist analyze all samples. And also, we always search for associations between marker staining and clinical pathological parameters. On this slide, you can see some association with clinical pathological parameters, and the low expression of mammoglobin in breast cancer of no special type was linked with high tumor grade, with loss of estrogen and progesterone receptor expression, and also with triple negative status, but is unrelated to breast cancer survival. In endometrial cancer, low mammoglobin expression was linked to advanced tumor stage. And the same trend was observed in ovarian cancer, but this data not reached statistical significance. And in conclusion, I want to say that mammoglobin A can be highly expressed in various tumors, mostly derived from the breast, ovary, uterus, and the salivary glands. In our study, mammoglobin expression was shown as not a major prognostic features, and the fact that mammoglobin A expression was only found in a few non-vital tissue in our normal tissue screening set provide further support of mammoglobin A as a potential attractive therapeutic target. Thank you very much for your attention.
Thank you.
So previously, hemoglobin has been used as a marker in metastatic tumors
Yes.
to define site of origin.
Yes.
Based on your study, would you recommend that or discontinue that?
No, yes, we recommend this. We also use mammoglobin expression as diagnostic markers in a panel for differential diagnostic mammocarcinoma from other types of carcinoma. For example, with lung carcinoma, we can use it. Lung carcinoma don't show positivity for mammoglobin. On with urothelial carcinoma, it's very important, while mammocarcinoma and urothelial carcinoma both show positivity for GATA3. And yeah, we use mammoglobin. It's really very useful marker.
Okay, thank you. Now, move on the last part of this session. We will be having a workshop session by Barsha.
Yes.
It's a presentation, right?
Yes, but would like to yes, it's open it and join. Not in possible. I have sent a link to this, or maybe I can just connect my laptop.
I don't know. Really don't know.
Because
Yeah,
we have the presentation.
You should have said this before. Yeah.
Yeah. Okay, we'll see. So I have sent a link to the presentation by email. It's on Google Drive. It is possible to change this, and we need to go with this one. Okay, so just this one. Change the no, no, that's too much. Change them. Yeah. Okay. One, two, three, okay. I think I will need to go with this microphone. Hello, ladies and gentlemen. My name is Jarosław Kwiecień. I am the CTO of Cancer Center AI, which is a Polish company founded to improve the cancer diagnostic process by applying computer science, including artificial intelligence. And with me is Dr. Artur Bartsch.
I cooperate with Cancer Center to help them with AI in this field.
Okay, so today I would like to share with you our experience and the results of our research project, which is focused on improving the prostate diagnostics by involving artificial intelligence. So first, let's take a look at the prostate cancer diagnostic pathway. Today we will focus on the right-hand side part of the image, which is which mostly involves medical imaging. So when he has an MRI scan, and then the radiologist identifies regions which are likely to have a cancer. And then if there are any such regions, then a urologist takes a biopsy and histopathology analysis is performed, which leads to the final diagnosis. And in our project, we developed two algorithms which to help to support the two stages here, so the radiology step and the histopathology step. It was part of the project called Advanced Prostate Cancer Diagnosis using machine learning and deep learning methods. It lasted for over 2 years and involved both data scientists and programists and medical experts. The first algorithm made in this project was a prostate segmentation algorithm for MRI T2 scan. It performed prostate segmentation, and it can segment either the full prostate or separately peripheral zone and central gland. It can also calculate the prostate volume automatically based on the segmentation, which is more precise than the standard ellipsoid method. The algorithm was trained on a huge data set. We had over 2,000 samples from 3 independent data sources, and the results were really good, really accurate, which was confirmed by achieving dice coefficient of 0.89 on the test set. When we have the result, it can be viewed in our integrated viewer in our platform, but it can also be downloaded and, for example, put into a device which performs a USG with MRI fusion to support the urologist when he makes the biopsy to see the prostate better. But we are on a conference focused on pathology. So now let's move to the second algorithm, which is which calculates the Gleason, which finds the Gleason patterns on a histopathology scan. So maybe I would ask Dr. Barszczak to tell a little bit about this Gleason score rating.
Do we have hematoxylin ozin of this? No. I'm wondering if some of you are uropathologists here. Okay, excellent. So probably you know the Gleason score, of course. So we have different patterns that we are looking while checking the pathology slides. And you know exactly that there are, as many as pathologists, of course, there is slightly known pattern skull, and we know exactly which pattern should be included while looking for the slides. But there is still differences between pathologists, and pointing if you are talking about the 5 pattern or pattern number 4 or 3. 3 is the most simple, but 4 and 5 might be slightly different between pathologists. So
yes, so actually this is the part when we wanted to present a few examples and discuss the results of the algorithm, but unfortunately due to some technical issues, this part is missing here. But we invite you to go to our spot there after the presentation, and we can show example of the results of the algorithm to show how it really works in practice. Yes.
This algorithm works that way that we have hematoxylin ozin slides, and after approximately 1 minute, 2 minutes maybe, it can transform and show exactly and mark exactly where is the pattern number 4, 3, or 5, and where is the healthy epithelium. So it helps, can be a big hand to pathologists to make a proper diagnosis.
Yes, so now I would like to quickly explain how we develop the algorithm. So when we want to train an AI model, the first thing that we need is a good data set. So we had a really huge public data set, which is called Panda data set, which consists of over 10,000 scans with automatically generated masks with recent patterns. But we had also private data sets from our medical partners, which included 100 scans with masks which were human labeled, confirmed by our medical experts. And we had also almost 1,000 scans with histopathology reports included. Yeah, and so we had a really huge data set, but it also had some technical challenges. I think the biggest challenge was to deal with the public data set, which is very, very big, but had also some mislabeled regions, and we put a really huge effort to identify the correct and incorrect masks. It was both automatic and manual to make sure that when we train the algorithm, we use really high quality data for this. We have developed a special tool for data annotation, which is integrated with our web platform, which was then used for our medical experts to annotate the data. So the algorithm works like this, that we have a whole slide image scan. We use the magnification of 10. And then we perform tissue detection. And when we detect the tissue, we split it into patches, smaller images, which are about 1,000 by 1,000 pixels. And then we apply a neural network to make a segmentation. So this is a map which shows exactly the regions of healthy epithelium and Gleason patterns 3, 4, and 5. And then based on the segmentation, we calculate the statistics, and based on the statistics, we can decide what is the final classification for a slide, Gleason classification, and then ISO grade. Yes, so now let's move into details. So first of all, we have tissue detection, and it seems to be a quite simple task, but we wanted to make sure that there are no artifacts. So we trained a simple neural network model for this, and it was done in 3 steps. The first step was to generate masks using a simple algorithm, which was just based on thresholding. And then when we had masks, they were quite good, but not perfect. So then a human looked over all of these masks and corrected the results using our annotation tools. And then we trained a neural network on this. As you can see in the slide, in this example, it works really well. It can even deal with artifacts like red pen in this example, so that only tissue is detected. And then once we detect the tissue, we need to split it into patches. And we wanted to do this in quite optimal way to use the topology of the tissue, the shape of the tissue, to make the patches reflect the actual shape of them. And we use several graph algorithms for this. So thanks to this, the algorithm works quite fast, and also the results are more accurate because the patches contain the bigger context, the bigger part of the tissue image. Yeah, and finally we have the most important step, which is feeding the patches into a neural networks which performs the segmentation. So for those of you which are interested in deep learning, I can say that it was an encoder-decoder structure, where encoder part was a convex network and the decoder part was made by ApperNet. Yeah, and then finally we have the results. When we speak about applied science, it is always good to say also about the possible challenges which are when we go with this model to the production, to the real usage. And in histopathology, usually the most important challenge is how to adapt to different laboratories, to scans from different labs, because all of them uses different setups, different tools are used, different scanners, which leads to the differences in the final images, final scans. So to make the model adapt to such variety of data, we used very extensive data augmentations. Data augmentation is a technique used in deep learning, which generally means that when we have a training input image, we make several random transformations on them, like changing the color space or rotating, scaling them a little bit. We spent really a lot of time to find the best augmentations, which make the model to be general enough to work with the data from the laboratories, which weren't included in the training data set. And also we made sure to have a variety of training data. We use data from 4 different laboratories. Each of them was a little bit different. So finally, we believe that our model generalized quite well. Yeah, and what is important is also that this model is already deployed in production. It is working, and you can try it out. We have published our web-based platform. It is available at platform.cancercenter.ai. You can make a free account there and upload up to 5 slides monthly, and then if you need to upload more, you can buy a subscription. This can be used not only for AI, but it is generally used for storing, viewing, and sharing slides to other pathologies, because it is cloud-based. So when you upload an image there, it is easily accessible from all over the world to any person that you will share the slide. And AI is integrated there. It is really easy to use. You just need to do a few clicks to have the AI result. And tomorrow we will talk more with Dr. Barszczak about the case study, how their laboratory transformed to fully digital working histopathology lab, and they did it using our platform, our web-based platform. Yeah, and for this, that's all. Now invite you for questions, and if you would like to see more about this model, look how it works, then I invite you to visit our spot there.
Thank you for a great presentation. We'll begin with Dr.
Thank you for this presentation, Gonzalo. So when you do the training, can you hear me? Perfect. So what type of scanner that you use for training?
So we had 3 or 4 digital scanners. Do you ask about the producers of the scanners, or? Okay. So we used some of the scanners were from Roche scanner, and I think there's like big format. Some of them were scanned with Hamamatsu scanner, but generally we support, I think, all of the formats which are available on the market from all scanners.
Behind the idol, it's right there.
how do your work perform using the language?
Okay, so yeah, that's a good question. Regarding DICOM format, actually we haven't had already a use case for DICOM format, but it is easy to integrate for us, and we can support the DICOM format. And actually, it doesn't affect the usage of AI, because when we upload the scan, it is processed into our internal format, so we can support any format, convert it to our, and then AI is applied on this standardized unified format.
Right, but the problem when you, like you say, convert it to a digital format, that might really, you might lose some of the data compared to that format. So, most of the AI right now, but really, if you push to do the analysis, that company is number one, right? What are your, right now, is this commercially available?
So currently it is available for research purpose, yeah, because we are still for certification, but it is available for everyone to try it.
Is this a cloud-based only or premise?
Both versions are available. Yeah.
Thank you so much.
Simple, another question? Okay, well, now we'll have a group picture. Thank you for the presentation. After group pictures, we will have lunch.
Thanks. This one. Okay.
happens in it.
Okay.
You can take it like this, so you can
Yeah.
read.
Okay.
Yeah.
Perfect.
Yeah.
I like that. Size of the I have. And I'll try to read that.
It's fine.
Yeah.
It's good.
Maybe 3 minus 2. Well. I say, all colleagues collaborating with especially litigation. This is not wrong. So. Stuff that shouldn't happen. Do someday have your house. I can't. I'm working. Strategy is always hard for the yeah. So. Well, Yes.
So, good afternoon, everyone. So right now, we will start the afternoon sessions. So we are presenting right now the poster presentation. So Simon Ken is going to present the KLK7 expression in human tumor, a tissue microarray study on 13,447 tumors. Feature forward so we can have more interaction to present. Thank you so much.
So, hello everybody, after lunch, to my little poster session, which we did on antibody validation and a possibly new diagnostic and prognostic marker, kallikrein 7. And in this study, we analyzed more than 13,000 tumors to reveal some prognostic and diagnostic information. And what we also did, we want to understand the expression of KLK7 in normal tissues. So these are my disclosures. And at our institution, at the university hospital, we do a lot of research on antibodies, which could be new diagnostic tools in differential diagnostic of different kind of tumors. And we also want to understand the role in normal tissue, and as I said, in different kind of tumors. And there are so many antibodies, but there are only a small number which could be useful in diagnosis, in the routine, and also for prognostic information. So only a few antibodies are applicable for the daily business. What is kallikrein 7? So most of you know kallikrein 3, which is also called prostatic specific antigen, so PSA, which is a useful marker in prostate cancer. The kallikreins are a family of 15 serine proteases, and they participate in a diverse range of cellular processes and pathways through regulating proteolytic cascades. KLK7 is mostly known in squamous epithelium, where it's expressed in the stratum granulosum, and its role is the discrimination of corneocytes. And therefore, it plays a potential role in maintaining skin homeostasis. In cancer, KLK7 was suggested to represent a route for metastasis through epithelial mesenchymal transition of tumors, because it's also a part in pathways of cell junction, and also plays a role in the connection with extracellular matrix proteins. If you want to look, or if you want to have a look where this protein is expressed, you can have a look at the RNA expression atlas, which you have access to. And there you can see that KLK7 is mostly expressed in the head and neck cancers, but also expressed in different kind of epithelial tumors of the ovary, also of the gastrointestinal tract, and also, for example, in melanomas. If you have a look in the literature, you can see that there are only a small numbers of studies which have been done on this protein. You can also see that a big part of these cancers which were analyzed are squamous cell carcinomas because of the role of the discrimination of cornocytes. And as you can see, the number of investigated cases was small. So none of these studies analyzed more than, I would say, 1,000 tumors. As my colleague Natalia explained, we are working with the antibody validation program. So we try to compare our antibody results with NR expression profiles, or we compared with the use of other antibodies. And this is called the independent antibody strategy, which we also used in this study. Here you can see a picture of our TMA, of our tissue microarray, which we use for the big antibody studies. And this block represents one slide, which you can analyze under the microscope. And there you can see, so these are tumor spots and also normal tissue spots. And there you can see that you can analyze more than 600 different cases at one slide. So we can do large studies with only a small number of slides, which we can look up in the microscope. And in the antibody comparison, so in the independent antibody strategy, we did the independent strategy. So we compared our antibody, our monoclonal antibody, with another antibody. And what is a specific antibody? So antibody 1 is, for example, the antibody we used, which was a monoclonal antibody. And antibody 2 was also monoclonal antibody, but it binds on another epitope of this protein. And what we want to reach is that we have a highly specific antibody. So antibodies, they have cross-reactivities we want to diminish. And if one antibody shows a positive staining, for example, in cells of normal tissues, which the other antibody doesn't, then it's a cross-reactivity. And if both antibodies show this expression, maybe that has also prognostic relevance, but we want to diminish cross-reactivities to reach a mostly highly specific stain. Here you see tissue spots from the normal tissue array, which we also did in our study. So we stained 76 tissues, normal tissues, benign tissues, and there you can see what was also written in the RNA protein atlas, that 5R7 is mostly expressed in the upper level of the squamous epithelium, and also in the tonsil you have a bit of squamous epithelium, so there you have also a little positivity, and a scattered few unspecific cells in the normal tissue were stained in the fallopian tube and the submandibular gland. The other tissues, the normal other tissues, were mostly negative. This is the picture my colleague also showed. So you see here the paraffin blocks of our TMA with the normal and the cancer tissue. And these were our scoring criteria. So we have highly specific conditions. So the tissue are cut at 1 day, are stained at 1 day, and are all scored with these criteria. So you have a highly comparable results after this study. And in this graphic, you can see the positive cancers which were stained. So the blue dots are all positive cancers, and the red dots are the highly stained or dark stained cancers. And there you can see that mostly, or the highest number of staining was seen in squamous cell carcinomas of different types. But there were also cancers which were not known before. For example, adenocarcinomas of the GE tract, pancreatic adenocarcinoma, and epithelial tumors of the ovary. So not only squamous cell carcinomas, but also different subtypes of other tumors. And here are pictures of the staining patterns. For example, in the squamous cell carcinoma of the vulva, squamous cell carcinoma in the oral cavity. Urinary bladder tumors also often show some squamous metaplasia or squamous differentiation. So you can see also there positive staining. Yes, in pancreatic adenocarcinomas, you see also some positivity, and also in tumors of the GE tract. CALCA7 has also prognostic relevance, which you can see here in colorectal cancers. The positive staining was linked to a positive nodal status, to vascular invasion, and also to lymphatic infiltration. So colorectal cancers which express CALCA7 are maybe more aggressive cancers. In squamous cell cancers, CALCA7 expression was linked to lower grade cancers, which could be explained of the role of CALCA7 in desquamation and keratinization, because keratinization and desquamation in squamous cell cancers is known to be linked to a lower grade tumors, because if they lose keratinization, squamous cell carcinomas, they are more linked to grade 3. So in conclusion, CALCA7 expression predominates, as we saw in our analysis and before in the NR expression atlas, in squamous cell carcinomas of different organs, but it is also common and new that it's expressed in ovarian cancers and cancers of the GE tract. And maybe that's also a possible target for future therapies. And as we saw in colorectal cancers, it has also prognostic relevance. Thank you.
Very nice poster presentation. Any questions for present? Okay. For Dr. Simon again. Thank you, Simon. Our next poster presenter, Dr. Florian Weideka, and he's also from the Institute of Pathology, Hamburg, University Hospital, Erfurt, and he's going to present patterns of estrogen receptor expression across 18,500 tumor samples obtained from 149 cancer types.
Here. Hello to everybody. Nice to talk in front of you and represent the next study about our immunohistochemical studies at our institute in Hamburg-Eppendorf. It's the pattern about the estrogen receptor in over 18,000 tumor samples. And here are some slides you will see again because my colleagues did it already, but I will explain something about the estrogen receptor. So if you ask, so what's new about the estrogen receptor? I know there is a lot of work done about the estrogen receptor, but we wanted to show not just the staining in the most gynecological or breast tumors. We also want to show which other tumors are positive maybe for the estrogen receptor. And I guess if you knew, the estrogen receptor is encoded on chromosome 6 at the ESR1 gene, and it's a transcription factor that regulates growth and differentiation of organs of the female reproduction system and some other organs, and is, as you know, a most important target in breast carcinoma as well, and is a prognostic marker for survival because estrogen receptor positive tumors do have a favorable prognosis. And yeah, there are hundreds of published studies and in human tumors, but prevalence of the estrogen receptor, particularly in non-gynecological and breast tumor, is still poorly understood. That's what I show. Here is a map of the whole studies made with estrogen receptor immunohistochemistry in different tumor types in the literature. As you can see, for example, in I can show you, it's a little bit, oh no, I can't show you, in let's go backwards. For example, in the lung cancer, there's a wide range of studies with no positive tumors for estrogen receptor or high expression. And so we want to show overview with a validated antibody, how at our big TMAs cut sections, the estrogen receptor is presented in other tumors. And this is the picture you've seen before, so I will skip a little bit. That's our TMAs with over 18,000 tumors from 149 tumor types. And we do have also some clinical data, follow-up, survival and stuff, especially from breast cancers. The normal tissue you've seen as well for our validation of these antibodies, and we used the MSVA 464A antibody. We did a comparison with a second antibody for the correct validation of antibodies, and it expressed like the same, like the second antibody is the CellMark SP1, and as well as to comparison with like RNA or protein atlas, estrogen receptor expression was seen in ectocervix, endocervix, myometrium, as you know, where estrogen receptor is expressed. This is our multi-tumor array. You can see here the whole slides with over the 149 tumor types. This includes over 2,000 breast carcinomas, 182 endometrioid carcinoma, and some more gynecological tumors. And the results, it's a little bit not too good to read at that slide here, but as you can imagine, most of the estrogen receptor expression was in the tumors from the breast and the gynecological system. So these are the bands you see on the left side. But there are some smaller peaks in some other tumors I will show you in a few slides. This again is not so good to read, but I will show you now in, for sure, invasive breast carcinoma, no special type. There's no surprising that in over 78% of our tumors, there was a positive expression, as well as in some leiomyosarcomas. They do express in about 23% estrogen receptor. And some other tumors you maybe not know, or you wonder if they do such expression of the estrogen receptor is for example the angiomyolipoma with 10% positive tumors, and as well as the Ewing sarcoma, for example. So this maybe could be a pitfall if you've got maybe a metastatic of a breast carcinoma. I know there are some more markers for breast carcinomas, but Ewing sarcoma, here was positive in about 5%, as well as adenocarcinomas of the salivary gland, and as well as here an example of papillary thyroid carcinoma as well. And some urothelial carcinomas showed at most some moderate expression of the estrogen receptor, as well as there was a case with the adenocarcinoma of the colon. And here, that's why you just, so we just did that study to show that you're not just going to use the estrogen receptor and say, okay, that has to be from that or that system, and maybe think twice if you've got a special tumor at a special site that not looks like a gynecological primaries. Yeah, the estrogen receptor in breast cancer has, if you could imagine or if you know already, an impact on the stage and the grade of the breast cancer, because with lower expression levels in estrogen receptor, so there's often a higher PT level, a higher G grading, or a nodal staging, and it has no significant, but a tendency to has a better survival prognosis, maybe if you know, because of the better therapy with the successful hormone therapy with estrogen receptor. Our conclusion is that the estrogen receptor strongly predominates in gynecological and breast tumors, so that was no surprising for this study, but we had some rarely significant estrogen receptor expression in non-breast and non-gynecological neoplasms as well. Thanks for your attention.
So our next poster presenter, Dr. Natalia Gorba, is also from Institute of Pathology, Health Center Hamburg Capital, and she's going to present the abrogation of TR3 and reduce expression of PD-1 or immune cell subsets in advanced prostate cancer.
Dear colleagues, I am pleased to present our work on some aspect of tumor microenvironment in advanced and primary prostate cancer. These are my disclosures. So prostate cancer is a very common tumor, and it behaves usually in indolent manner, but a small proportion is highly aggressive, can be refractory to therapy and lead to patient death. And it's broadly known that tumor microenvironment plays a very important role in tumor behavior, tumor biology, but primary and advanced prostate cancer is known both as non-inflamed cancer, characterized by a positive immune infiltration. In our institute, we see a lot of prostate cancer every day, and some of this prostate cancer sometimes have a really dense immune infiltrate, and aim of our investigation was to assess the special interplay of more than 30 immune checkpoint expressing immune cell subpopulation in the tumor microenvironment in more than 440 prostate cancer. For this investigation, we use multiplex fluorescent immunohistochemistry investigation with staining 21 immunohistochemical markers in microtissue array analysis. But problem we were faced that most non-expensive scanners can deal only with a few antibodies at a time. But for characterization of tumor microenvironment, for most relevant immune cell subtypes, we require simultaneous staining of at least 15 antibodies. And tissue microarray slides with more than 400 tumors measures about 2 by 3 centimeters, and such that areas cannot be analyzed with many high-end devices for multicolor. And how to analyze more than 20 antibodies on one slide with a 3+1 scanner? Solution is staining and bleaching and again staining. So our bleach and stain method was conducted in 7 sequential identical rounds of staining and imaging, and each round consisted of staining with 3 antibodies. Here you can see a line of first antibody, then second, and with horseradish peroxidase conjugated antibodies, and also conjugated with tyramide and fluorophore. Short incubation, short treatment and microwave remove all antibodies, but fluorophore remains on the tissue. And the same we made with second antibodies and also with third antibodies. Then follows contrast staining with DAPI and scanning with image obtaining. And then bleaching step. For bleaching, we used simultaneously photo bleaching with metal halide lamp, incubation in solution of 3% hydrogen peroxide, and also cooling with a lot of ice. And this process of bleaching stops as soon as fluorochrome signals from all fluoroforms was vanished. So this is first cycle. Staining, contrast staining, imaging, bleaching with 3 markers. Second cycle, all cycle is identical. They differ only with antibodies that we used. Third, fourth, and 7 cycles. And then all these electronic photos was aligned with special software and thus merged in 121+1 photos according to a DAPI signal. Here you can see tumor microenvironment of individual microtissue array spots. And you can see that in first round, we stained checkpoint molecule TIM3, PDL1, then fine cytokeratin for epithelium. Second round with antibodies for macrophages and dendritic cells. Third round with markers for different type of lymphocytes, then for FOXP3 for T regulatory cells, PD1, CTLA4, then Ki67, and so on. And what is very important for such investigations, we have to be sure and reliable of our antibodies. That's why all our antibodies extensively validated in our microtissue array analysis with more than 60,000 samples. Here on this slide, you can see our protocol details. You can see antibody that we use, type from opal dyes, and cycle, number of cycle. And what is very important, we must use in first cycle antibodies for weakly expressed proteins. And further, we can stain our tissue with antibodies for strongly expressed aspects of our investigation. And what can we do with this method? Firstly, identify all cell types in tumor microenvironment. Tumor cells itself with pancytokeratin, different type of T lymphocytes, the helper, the cytotoxic cells, regulatory T cells, and B lymphocytes, different type of macrophages, and also dendritic cells. Also, we can investigate functional state, positivity or negativity to 7, positivity or negative PDL1, and also special parameters, localization of immune cells, intraepithelial or stromal, then cell-to-cell contact, cell distance, CD32 one as an association with vessels and so on. Our patients cohort included 443 patients with 218 primary prostate cancer and 235 advanced prostate cancer. And here you can see a typical slide, typical microarray slides with all our staining, and each spots measures 0.6 millimeter. And yet to our result, on the left diagram, you can see that density of immune cells increased constantly along with Gleason grade. So the less differentiated tumor was, the denser were immune cell infiltrate. And on the right diagram, you can see that in advanced cancer, infiltration of immune cells were even more greater than in primary prostate cancer. So in general, there was the tumor, mere immune cells we see in the tumor microenvironment. About functional state of immune cells. So in our study, we don't find significant difference between expression PD-1 in CTLA-4 in primary and advanced prostate cancer after therapy. Also, there was a slight difference, but it was not statistically significant. And what we found, it was substantial statistical significance in expression on TIM3 and PD-1 in immune cells between primary and advanced prostate cancer. On the left diagram, we can see that there was upregulation of TIM3 in all cell subtypes in advanced cancer in comparison with primary cancer, and PD-1 showed conversion results with downregulation in secretion of PD-1 in advanced cancer in comparison with primary cancer. So in conclusion, I want to say also prostate cancer is possicellular cancer, but a degree of tumor infiltration by various immune cell subtypes increase with tumor progression in primary tumor and also in recurrent tumors under therapy. That we found only a little difference in PD-L1 in CTLA-4 expression between early and advanced prostate cancer, and it was not statistically significant. And substantial difference was obtained in PD-1 and TIM3 expression between early and advanced prostate cancer, and it gives us additional information about tumor biology, and it requires, in any case, further investigation in larger cohort of patients with prostate cancer, and can be some tools for target therapy in the future. And you can see that bleach and stain method is very suitable for such investigation with a lot of markers for investigation of tumor microenvironment. And this method enables an upgrade from 3+1 to 21+1 multiplex fluorescence immunohistochemistry. Thank you for your attention.
Yeah. Thank you so much. Okay, so our next poster presenter, also a chairperson, Son, from internal medicine of Snap Health, Louisiana. She's going to present a case of gastric adenocarcinoma in the ruminant stomach after one-wide gastric bypass.
All right. Good afternoon, everyone. Thank you so much for this opportunity to present to you. I'm just going to switch gears a little bit from all the fantastic research that all the previous presenters have done. I'm going to talk about a case, a clinical case that I saw during my residency at Ochsner Hospital in Louisiana. This was a case of gastric cancer that we found in the remnant stomach after a patient had a Roux-en-Y gastric bypass that she had 20 years prior. I did write this case up with my colleague, Dr. Rona Eviai. unfortunately was not able to attend today. So just some background information, some introduction. Gastric cancer is the 5th most common type of malignancy worldwide. Routine screening for gastric cancer, however, is not typically performed in the States due to its actual low incidence, specifically in the United States. Diagnosis can be delayed due to this fact, due to absence or rather non-specific nature of presenting symptoms, usually weight loss, fatigue, and anorexia as well. So gastric adenocarcinoma in the remnant stomach after a Roux-en-Y gastric bypass is not unheard of. However, it is an exceedingly rare case. There's only ever been a few cases reported in literature, and bypass surgery has actually not been established as a risk factor for malignancy either. So let's just jump straight into our case. Our patient is a 50-year-old female. She does have a history of breast cancer, SAS post radiation and partial mastectomy. She was morbidly obese on presentation. She had a BMI of about 42, and 20 years prior, she did have a Roux-en-Y gastric bypass. Her BMI at that time, before the bypass, was 63. She presented with 5 weeks of nausea, vomiting, constipation, abdominal pain, and significant weight loss of 60 pounds. She was initially admitted to the primary general surgery team since they were the ones who performed the gastric bypass, and they thought that her symptoms might have been related to the subsequent anatomy. She also developed an inability to tolerate solid food. She developed ascites and bilateral pleural effusions. She did have a globose yet soft and massless abdomen on exam. However, that was diffusely tender to palpation. There was otherwise no specific exam signs on presentation. During her hospitalization, she did have a paracentesis and a thoracentesis both performed. However, no malignant cells were found on cytology of either fluid. She didn't undergo surgical diagnostic laparoscopy with the general surgery team combined with an intraoperative EGD or esophagogastroduodenoscopy. They did find diffuse adhesions consistent with peritoneal carcinomatosis. However, they did not, however, find any lesions that were concerning for primary cancer. They did biopsy the cancer and they did find adenocarcinoma, however, of unknown origin. The surgery also revealed intact post-Roux-en-Y gastric bypass anatomy and no otherwise obvious cause for her symptoms. Due to the other findings of the adhesions and the inflammation, the small bowel inflammation, they initially thought that it was SBP or spontaneous bacterial peritonitis, especially in the setting of her ascites, despite the fact that she had no other liver medical history, including cirrhosis. However, despite treatment with antibiotics, her symptoms continued and worsened subsequently. By that time, our team was the hospital medicine team. We were consulted by the surgery team and we decided to get a CT scan of her abdomen. And we found a diffuse peritoneal carcinomatosis that extended beyond what the surgeons were able to see intraoperatively. This raised suspicion for ovarian primary malignancy due to her history of breast cancer, as well as some lesions that were found on her ovaries. We got the OBGYN team and the gynecologic oncology team on board as well. They recommended getting a transvaginal ultrasound or TVUS. However, it did not reveal any adnexal masses, although CEA and CA125 were elevated and CA19-9 was normal. Of note, CEA and CA19-9 are typically associated with gastrointestinal cancers. However, CA125 is typically associated with ovarian cancer, which then pointed us more in that direction. However, the lack of adnexal masses actually pointed us away. At that point, we were concerned for GI cancer of unknown origin, so we recommended getting a GI team involved. They did a double balloon endoscopy, which then revealed an inflamed and ulcerated pylorus, as well as an irregular appearing mucosa in the remnant stomach. At this point, we found out that the GI team actually could not advance due to all the severe stricture and the lesions that were around the actual entrance of the remnant stomach. They took biopsies of that area and they found stage 4 gastric adenocarcinoma. This was poorly differentiated, and we called it stage 4 because it had already metastasized to diffuse peritoneal carcinomatosis. So opening this up after the discussion, reason why this case was interesting was that it basically illustrated a really rare case of a gastric cancer in the remnant stomach. Of note, obesity has been identified as a risk factor for major GI cancers. Hypotheses explaining this include excess adiposity, including causing altered insulin and IGF signaling, as well as chronic low-grade obesity-related inflammation and altered hormone metabolism. It is reasonable to think that the treatment of obesity, such as bariatric surgeries, in our patient's case, Roux-en-Y gastric bypass, would serve to reduce overall GI cancer risk. Some studies support this notion as well, especially in female patients. On the other hand, however, there is some controversy given that some reports of gastric bypass has actually shown some increased association with increased risks of GI malignancies, particularly colorectal cancers. So therefore, there is actually guidelines in the U.S. that state to increase colorectal cancer screening using colonoscopies for patients after gastric bypass. However, there are no studies that support an association of gastric bypass surgeries with gastric malignancies. As such, there's still a very low incidence of gastric cancers in general, so therefore there is no screening guidelines that exist in the US as of yet. There are, however, a few but yet important case reports, this one being one of them, that detail stomach cancer incidence after gastric bypass. In the case of Roux-en-Y, the remnant pouch is a potential location, which is very significant and is not typically evaluated on an routine endoscopy. In our patient's case, she did have an intraoperative endoscopy. However, that didn't show anything because the remnant stomach was not routinely evaluated. There are widely accepted benefits of bariatric surgery, such as improvement of chronic metabolic diseases, sleep apnea, hypertension, even diabetes control as well. Estimated about 600,000 bariatric surgeries are performed each year worldwide. More than half of them are Roux-en-Y gastric bypasses. It is important to evaluate for the potential complications of malignancy in these patients, especially since right now there are no other guidelines besides increased colon cancer screening. Bariatric surgery patients go through a rigorous screening process, including being able to maintain a healthy lifestyle afterwards, because there are many different types of bariatric surgery, Roux-en-Y being the most common. However, there is also gastric banding, which can fail if the patient fails to actually regulate their intake, especially in the immediate postoperative period. In order to qualify for either procedures, they must be aware of all the risks associated with the surgery, including the risk of increased malignancy. Potential future research may include high-power studies to completely evaluate the risk of stomach cancer in these patients. It is important research topic in the GI and cancer world, as this procedure will only become more common as obesity rates continue to increase worldwide. However, we hope that this case can illustrate the importance of actually keeping this on your differential if you ever have a patient coming in with non-specific symptoms, especially with history of gastric bypass. These are just some images of our patient's endoscopy. It shows that the entrance on the bottom left, you have the entrance to the remnant stomach, which actually they were not able to advance the scope far enough into that because it had already strictured, and they took biopsies of that area. On the bottom right, you can see some lesions which show the poorly differentiated adenocarcinoma. This is just a quick little diagram of essentially, I probably should put this in earlier, but this is what a gastric Roux-en-Y bypass looks like. You have a normal stomach anatomy with the duodenum and the jejunum on the left side. On the right side, after Roux-en-Y, the gastric pouch is only that little left over. It's an anastomose with the jejunum. And then you have the remnant stomach, with the bypass duodenum, which essentially is left in the patient because there's way too many vessels and nerves involved in it, and it is allowed to atrophy and essentially becomes a vestigial part of the GI tract. Oh, and also one more thing is a double balloon endoscopy. What it does, it basically goes through the gastric pouch, through the jejunum, and basically tries to link into the bypass duodenum. In our patient, it actually stopped right here. So we went into the remnant stomach. These are a couple of our references for this presentation. Otherwise, thank you for your time and open to any questions.
So your main problem is basically trying to make a diagnosis or making endoscopy, try to do endoscopy diagnosis on that case.
Correct. Yes. In this particular case, the diagnosis was delayed because no one had thought to look into the remnant stomach until after we had rolled out everything else. In our patient's case, she already had presented with 5 weeks of symptoms. At that point, it had already diffusely metastasized. We ended up sending her home with hospice afterwards. But after the diagnosis, she was just happy that she actually knew what was going on. But unfortunately, at that point, our oncology colleagues didn't recommend even palliative chemotherapy because it had already spread too far.
Any other question? Okay. So our next poster presenter, Dr. Sebastian Bergman Friedhoff, is also from the Institute of Pathology, Hamburg University Hospital, Eppendorf. He's going to present what 5AC expression is linked to mucinous endometrial subtype, absence or nodal metastasis, and mismatch repair deficiency in ovarian cancer.
Where can I turn the presenter mode on? So, full presentation and presenter mode. Yeah, this one. Oh, thank you. Go. Yeah, thank you. Dear colleagues, my name is Sebastian Dwertmann-Rico, and I would like to present to you our study MUC5AC expression linked to mucinous and endometrioid subtype of ovarian cancer and also to the absence of nodal metastasis. As well as in our other studies, I have to make the disclosure that the antibody that we used was provided by a company that is owned by a family member of a co-author. So in general, ovarian cancer is the 8th most common cancer in women and the 5th most frequent leading cancer cause-related death, with over 300,000 new cases a year, and surgery and chemotherapy are often not sufficient. Of course, there are new treatment options like also immune checkpoint inhibitors. However, the response rate in ovarian cancer are often lower than in other cancer types. And also, ovarian cancer could be has histological challenging due to the different subtypes and also molecular subtypes, and also the ovaries can also harbor metastasis from other cancers. So what we did, we analyzed the correlation using 5AC to these ovarian cancers. C is a part of a family of the mucin family and is also expressed at the same gene cluster region as other mucins like MUC2, MUC5B, MUC6, and MUC19, and is normally expressed in epithelial cells to protect from chemical and mechanical stress. And in the literature, MUC5AC might have a potential role to distinguish mucinous ovarian cancer from other subtypes, or maybe also metastasis. And this was why we wanted to analyze that further. So our study aims were to clarify the status of MUC5AC, and also to compare it to different tumor parameters, to the tumor aggressiveness, and if it is linked to the microsatellite instability. So, like in the other studies, we also used the tissue microarray here with over 600 tumors of ovarian cancer, and each spot measured 1.6 millimeters. And we used the clone that I mentioned that was previously also validated in another study. So the advantages of a TMA was shown by my colleagues before, but it is very important to use freshly cut slice for these studies that we also investigated in a study before. Here we can see the example of HER2 immune expression in a slide cut 1 week before staining with a strong expression, and the same tumor in the slide cut 6 months before staining with a much less expression. And this is not only for HER2, but also for other immune histochemistries like estrogen receptor, or as shown here, also progesterone receptor, E-catenin. So in general, for every antibody that you use, you should use freshly cut slice. So we had our paraffin-embedded block of ovarian cancers, here the H&E slide, and in magnification we can see a spot of a high-grade serous ovarian cancer and below a spot of a mucinous ovarian cancer. And in the study we had over 600 tumors containing, most of them were serous carcinoma, but also 55 mucinous carcinomas, 56 endometrioid carcinomas, and also some clear cell carcinomas and triple NPs / carcinosarcomas as well. And for most of these, we also had some information about the tumor stage and the lymph node status, as well as for the microsatellite status. So as mentioned before, we use the same scoring criteria as in the other studies. So negative is no staining at all, and weak staining at least an intensity of 1, and under to equal 70% of the tumor cells, or intensity of 2 and under equal 30% of the tumor cells, and so on for the moderate staining and strong staining. And here are some examples of the stainings and the tumor types. We can see in figure A and B the serous carcinoma subtype with only a few cells positive, and in figure C we can see the endometrioid subtype with much more positive tumor cells, and as well as strong staining. And in the mucinous carcinoma here, nearly every tumor cell shows an expression of MUC5AC. So when we compare these data, we can see that most mucinous subtype ovarian cancer showed an expression, and also a great amount showed a strong expression of MUC5AC, followed by the endometrioid subtype. But as well, some carcinomas like carcinosarcoma, triple MT, showed some expression. And what we can see on the right side, this is was new for us, because in the literature these subtypes were mentioned to be negative. Because of the larger study, we could also identify at least some tumors with a moderate or weak staining. When we compare it to the microsatellite instability, we can see here a significant correlation to tumors that had expressed MUC5AC, were much more likely to be microsatellite instable, and this goes as well for especially the endometrioid subtype, and this may represent the same mechanism as it has been described in the colon cancer before. When we go to the tumor prognosis, we can see a significant correlation to the tumor stage. So a strong expression was associated with a lower tumor stage, and also was associated with the absence of lymph nodal disease. When we, this was over all cancers, and when we go to the subtypes, we can show at least a significant correlation to the absence of nodal disease, but not for the tumor stage. And this goes as well to the, This goes as well for the serous subtype. There we only had a correlation for the absence of lymph nodal disease. So in summary, the results show that MUC5AC is most commonly and strongly expressed in mucinous and endometrioid ovarian carcinomas, and is associated with a lower tumor stage and the lack of nodal metastasis, and could potentially play a role for serological disease monitoring if the tumor was positive, and should also, well, it could be followed by an MSE analysis. Thank you for your attention.
So mucinous tumors of the ovary are notoriously heterogeneous. So one of the drawbacks, or one of the potential pitfalls in your study, is to verify that your tumor microarray was indeed from mucinous carcinoma, not from borderline tumor, not from a metastatic tumor, not from a somatic multiple malignancy with mucinous differentiation. The other thing is that mucinous carcinomas typically have a significant differential with metastatic tumors, which would also be very commonly MUC5AC positive.
Especially colorectal cancers as well. So it might be not a good marker to differentiate metastasis from mucinous carcinoma. Yeah.
Any other question? Okay. That's right here. Maybe something that is very and here. So our next speaker, Dr.
Lina Temesian. She's from Pavlov St. Petersburg Medical University, and she's going to present the cytopathology, laboratory management, integrated approach to cytopathology.
Good afternoon. My name is Nina. I'm honored to be here. The topic of my presentation, my presentation is about cytopathology, the possibilities of digitalization and integrative approach in cytopathology. My co-author is a radiologist and oncologist. I work in medical university, and he is a professor, but he works in other clinic. So we all know that the father of cytology is American scientist of Greek origin, George Papanikolaou, who invented pap smear. At that time, the cytology reports. Yes.
Very good.
Okay. Okay. At that time, cytology reports were mostly descriptive. The first classification system came in 1988. It was a Bethesda system for reporting cervical cytology. After cervical cytology system came Bethesda system for thyroid cytopathology in 2010, which was revised twice. The last one came out this year. And after we have reporting systems for almost all localizations, Paris system for urine cytology, Milan system for salivary glands, Yokohama system for reporting breast fine needle aspiration cytology, international system for reporting serodiffusion. What we have now? It's incredible that now we have two essential tools, two WHO cytology classifications, which classify tumors from the point of view of cytologists. And I hope that in the future we'll have reporting systems for other organs as well. Compared to histopathology, cytopathology has many advantages. It is more simple, it is minimally invasive, quick, easily repeatable, and inexpensive method. But it has also its disadvantages. The first disadvantage is heterogeneity of the tumor, which cannot be diagnosed by cytology, but it is also not good for biopsy. So the second problem is difficulties to obtain sufficient material. What we do? Using US guided and CT guided FNAs with rapid on-site evaluation, we considerably reduce the number of non-adequate material. And at the same time, the rate of false negative reports also are reducing. Gray zone. What is gray zone? It is the The third category, a typical category in each classification system, which is it always exists, but the more a cytologist is experienced, the less atypical he or she has in his reports. Introducing a different diagnostic modalities like immunocytochemistry, molecular testings, biochemistry, electron microscopy, for example, for mesothelioma, seems to reduce the number of atypical cases. So, the cytology compared to histopathology, cytology is labor intensive, time consuming. There is always problem with staffing and the inter-observer variation. In the era of digitalization, these problems can be solved by digital cytopathology. What is digital cytopathology? Here is some key aspects of digitalization in cytopathology. Digital cytopathology is delivery of information which is captured which is captured for diagnostic and other purposes like education, archiving. That information can be integrated also in laboratory information systems. The recent pandemic, I know that in the US, but in Russia also, recent pandemic accelerated the adoption of telepathology. Unfortunately, in telecytology is a little bit in retard because of the questions related with three-dimensional nature of cytological material. But anyway, telecytology also is used. It allows cytopathologists to provide the diagnostics by reviewing cytology smear prepared by cytotechnologists or another qualified on-site operator. Advantages and disadvantages of telecytology are listed on the slide. The main advantage is the time saving. One pathologist can consultate different material at the same time. It is very useful for second opinion, and the least it is cost effective. The main disadvantage is it requires competent personnel, like competent cytotechs, and it requires specialized software and hardware. Digital image analysis allows to identify patterns and other data in pathology samples using artificial intelligence. In a giant screening, in giant screening, the most popular and the most famous are busy focal point imaging system and hologic team prep system, which are used, I think, more than for about 10 years, at least in Russia. And in non-GIN cytology, they are platforms which count biomarkers. But what about using digital image analysis for non-GIN cancer diagnosis? In 2022 article published in Cancer by Korean researchers reviewed many of the later applications, including thyroid, bladder, lung, breast, pleural effusions, ovary, pancreas, prostate. They concluded that the artificial intelligence models are still in the primary stage of development so far. None of them, that models, has proved sufficient for independent diagnosis of non-GIN cancer. And the main limitation is the lack of well-validated data sets. So we need for the future large multi-center data sets with future studies are required with large multi-center data sets. But I'm sure that digital cytopathology is a promising field. And the last two phrases, I don't know how you think, but we think that me and my co-author that artificial intelligence and machine learning should be included in medical school. And probably in the future, new specialty will be created by integration of pathology, cytology, computer science, and mathematical statistics for more accurate diagnostics of cancer and probably for prediction. So this is how Google defined integrative diagnostics. Nowadays, it's very popular. Integrative diagnostics refers to an approach in healthcare that combines information from various sources to provide comprehensive understanding of patients' health, and so on. And this is, I couldn't find definition of integrative cytopathology, but we created our definition, and we do believe that it has a future. The integration of data from medical history, clinical data, structural molecular imaging, laboratory and molecular tests, and utilization of artificial intelligence and machine learning will enhance the accuracy of cytological diagnosis. But anyway, we believe that it is the responsibility of physicians. The responsibility of physicians should be prior to artificial intelligence, as well as teaching and controlling all artificial intelligence-based machines. Thank you. قلت له ماما عندي
Sorry, many people just start to do it. So, I'm solving this resolution. So, choose to take a single fraud. Okay, single.
Yes. What is it? Okay. Oh. Yes.
That's what we will do. It's time.
No. And you? I'm afraid it's probably not great. Okay. Yeah. We able to agree. So, or did you below that abstracts? The last I get for Congress, years ago. Quite well attended. I think one by one. Like that. We should it. So, I thought it was more like night. Oh, yeah. Yes. To be honest, I will. So, but sorry. But topics are interesting. That's good work. And I meet people that are areas I have. Yeah. What's in the previous conference, it was sponsored by SCP. That's thinking claim, I guess. So, there's also another one. Happens into this. Well, I said it. Great. I guess.
It is virtual or it was
Okay. Oh, okay. Yeah. Okay. Thank you. Thank you.
It's just a journey. How the artificial intelligence can help some pathologic problems. So, the title, the head and neck squamous carcinoma is very difficult and complex disease. So I explain first, and I show you how I solved some tiny problems. So some people know the head and neck, but I'll explain very shortly. This carcinoma is originate from, as you see, from oral cavity and larynx and pharynx, especially in mucosal epithelium. So this, sorry. This area is very vast, and there is very different phenomena, as you can see, marked as cellular attack and squamous differentiation. So understanding these variety is crucial to effective diagnosis and suggest the detail. Sorry. This variation is very crucial to define the problems of head and neck squamous carcinoma. And I try to solve these problems as using deep learning problems. Everybody knows about the evolution of deep learning in medicines. So it is the area that within rapid growth and significant achievements, especially very vast areas, especially in image problems. In medical images, without artificial intelligence, the human power is needed because this is very hard problem to solve and very reliant to human resources. For example, but using artificial intelligence, we can solve many problems in medicine, especially in X-ray, MRI, and CT images. And we can also solve these image problems in pathological images. So I focused on problems, especially stage classifications in head and neck squamous cell carcinomas. The data, the source of data is the Cancer Genome Atlas data set, especially classified as head and neck squamous carcinomas. This is chosen because this can be easily accessed and comprehensive and representative data. We specially select in this to solve these problems. I corrected 100 and many patches images for each classes. So I can acquire, as you can see, 45,300 patches in 480 cases. Some people have questions why this patch is very small. Because I selected only 10 cases for balanced patches between each cases. And in TCGA dataset, there is a many patient data. So I corrected and summarized demographic and clinical background. In deep learning models, there are many models I can't explain. In these cases, I corrected efficient net
especially subtype B6. The efficient net has some modifications, some features which is called which can be selected, channel depth and channel width, and input image resolutions. The researchers who invited this efficient net made the optimal balance of depth, width, and image resolution. So I choose these models for deep learning models. And in deep learning model, weight selection is very important. In these studies, I chose pre-trained image net weight because when I compare this and random weight, I can get more good results when I use pre-trained image net weight. And there are many options in patches. In the cases, I chose 520 pixels and slide level 0. As I will explain, there will be some changes because when I change these parameters, we can get another results. But in studies, I choose that like that. And sorry, to make these problems as classification targets, I chose two groups as very high group stage 4 and low groups stage 1 to 3. In that case number is, as you can see, some balance because balance between 200, about 200, and patch image. As you can see, there are some balances in patch image numbers, and there are many methods to merge patches to classification. In the cases, I selected very simple method to evaluate possibilities of patch probabilities in the model that made the probability of each patches. And next, we should choose the data set splitting to make this model to decide to check this model is accurate. In the cases, I had some split between train validation and test set as 60 and 20 and 20 ratios. So these parameters I run many times, and when I get the models, sorry, there is some mistake in cases, but in this case, the area on the curve, you can see the 0.66 and 4.6 and 6.4. There is and in the cases there is 0.748. Some people can say this is very low, but in the cases there is a very significance, and as you can see later PowerPoint, there are some statistical significance. So you can see this survival rate between the model that can be between the group that separate by the models and the right models that can be right group separation between sorry, yeah, sorry. So there is very differentiation. Our model have more good p-values. So it can in our model there is genetic differentiation between upper and lower, and so our models can explain some others than classifications. So there are so many limitations and about interpretation as emphasized and another models, but there can be one clues to can get so can get the features in head and neck squamous carcinoma, and that can be used very another cancers and another disease. Thank you for about attending and have a good afternoon. Thank you.
So I'm not sure if Dr. Ian with that here. So the next presenter is going to be Dr. Sebastian Bertman-Regan. And he's going to present pattern of MAP6 expression across 119 different tumor types in a tissue microarray study on 10,412 tumors.
The presenter mode. When was in the presenter mode? Yeah. Yeah. That's okay. Thank you. You good? Thank you.
Yeah. Dear colleagues, it's me again, Sebastian Bertman-Regan, and I would like to present to you another TMA study, and I promise it's the last TMA study, at least for today. It's about MUC6 expression across over 100 different tumor types in a tissue microarray study with over 15,000 tissue examples. And of course, our disclosure that we used the antibody validated provided by a company that is owned by a family member of a co-author. So is likely like mucin 5AC, also part of the family of the mucin family, and is also expressed in epithelial cells, normally expressed in the stomach, the gallbladder, the colon, and the endocervix. And in the literature has described that MUC6 could provide some information, for example, in distinction between gastric and intestinal metaplasia and Barrett esophagus, and also in distinction in several pancreatic neoplasms. So we did a review in the literature, and here we can see, according to the different tumor entities, that the study results are very variable. There's a huge discrepancy. The red dots represent studies with under or equal 10 tumors, the yellow dots 11 to 25 tumors, and blue dots over 25 tumors. And if we look, for example, at the adenocarcinoma of the esophagus, here we have studies with 11 to 25 tumors with at least a 10% positivity for MUC6, and other studies shows positivity and over 80%. So there's a need to do a very critical evaluation, and the main reason is that we have seen before are different antibodies, different staining protocols and scoring criteria, and at least also maybe some smaller tumor tissue. So we did a large study, and before we do it on a tumor tissue microarray, we first evaluated the antibody on a normal tissue array, and then we get to the tumor tissue array. The tumor tissue array contained 119 tumor types with over 15,000 tumor samples, and we also had some information to the histopathological and molecular status. And also for the breast cancer, we have some information about the clinical follow-up. So as we showed before, we evaluate that antibody with another antibody and also compared it to ANA data, and then use a normal tissue array to compare these antibodies. And we could show that these antibodies are equal in expression, and MOX6 is normally expressed, for example, in the seminal vessels, the Barnard glands of the duodenum, or also in some glands of the stomach, and also some ducts of the pancreas. So then we could move on and do the staining on our tumor tissue microarray, and there we had 39 slides with tumor tissues, in summary over 15,000 tissue examples. And when we look at the data in a ranking order, descending ranking order, at the top is the small cell neuroendocrine carcinoma of the prostate, but we have to mention that these are only 9 cases, so it might be not that significant. But here we can see that other cases with a larger amount of tumor samples, for example, mucinous carcinoma of the breast, have a MOX6 staining, but also the gastric adenocarcinoma, as shown here, has a strong staining, at least in some percent of the tumors. But we have to mention that most of them does not exceed 40%, and none of them does not exceed 50% of tumor positivity. But as well, there are other examples that express MOX6, like adenocarcinoma of the pancreas or endometrium carcinoma, and interestingly, also recurrent adenocarcinoma of the prostate. And because of this larger study, we also could identify some positivity in urothelial carcinoma that was not described before. When we compare this data to the clinical pathological data, then we can see significant correlation to MOX6 expression linked to a higher tumor grade in breast cancer, and also to nodal metastasis, HER2 positivity, and negativity for estrogen receptor and progesterone receptor. When we look at the survival data, we had no significant correlation. We also analyzed the colon cancer, and there we can also see a significant correlation to the tumor status, and also for the right-sided localization, and also with microsatellite instability. But these are the only significant results. We also look for other tumor entities like endometrium cancer, but there was no significant correlation, as well as for the serous ovarian cancer or pancreatic adenocarcinoma or stomach cancer. So this marker is expressed in conclusion in a broad range of different tumor entities, but given that only two, this is not really exceed, none of them exceed 50%, and only a few reach 40%, this marker might be not well suited in the distinction of tumor entities. And there's no overall strong correlation to aggressive tumor behavior, although we showed it in some entities before. So, yeah. Thank you.
Any questions? First question.
other strategic is for you. So, so I apologize. I'm just going to announce assistant prof Najat today. She has some kind of emergency. That's why she's available right now. She is from Princess Nora University Staff Housing, and she's going to present the growth pattern fingerprinting for automatic analysis of lung adenocarcinoma overall survival.
Thank you. Thank you, Doctor. Good evening, everybody. I am Nada Subai. I received my PhD in 2019 from the Tissue Analytics Lab in Warwick University in the UK. And now I am an assistant professor in Computer Science Department in Princess Noor University in Riyadh, Saudi Arabia. My talk would be I will start my talk by talking about the computational pathology journey, where it starts and where it ends now, and then I will go over two of my recent works that we have done in lung adenocarcinoma specifically, and lastly I will conclude this talk. So we all know that histology starts with light microscope, where pathologists would sit, they would look at the tissue slide under the microscope, and they will estimate or make the diagnosis or prognosis. And then the slide scanners come, and then we were able to digitize the histology slide, and that of course brings a lot of benefits, including training, consultation from all over the world without the need to have physical slides in the same place with the consultant. And also this allows machine learning to show how successful it was, especially deep learning, because we all know that deep learning requires a lot of data. It requires a huge data. And that this is available with the histology slides. Some of the slides, they would be around 2 gigabyte, 4 gigabyte, and they are rich in information. They are different staining. So that was really useful in machine learning. We all heard about Chameleon challenge, for example. It was around 2016, I guess, where the machine learning were actually as good as pathologists in making prognosis and diagnosis. So the first work I'm going to talk about is the quantification of growth patterns in lung adenocarcinoma. So I'm not a pathologist, this is what I collected from the pathologist information. So they said that in the clinical papers, they said that there is a huge correlation between histology growth pattern and disease outcome, which is overall survival, disease-free survival, and response to chemotherapy. And lung adenocarcinoma contains several patterns, but the most common patterns are the solid, the lipidic, acinar, papillary, and micropapillary, as I show here in the slide. So we were interested to quantify these patterns and then make a prognosis based on that. So in 2011, the revised lung adenocarcinoma classification system was released, and it suggested the semi-quantitative estimation of the patterns, and they also replaced the mixed pattern with the predominant pattern. So if there is multiple patterns in the same tumor, and instead of using there is a mixed pattern, no, you can actually find the one that is dominating the pattern, and that would be the predominant pattern. So how we did that, we collected the whole slide images first, then we prepare the data set, we do the training and testing, and finally we quantify this automatically for the whole slide image and then make the prediction. Our data set were collected from the University Hospital in Coventry and Warwickshire in the UK, and they were scanned at 20.2075 micrometer per pixel using Omnix scanner. there were 2 pathologists, consultant pathologists who did the annotation, and then a junior pathologist to make the 3rd annotation, and then we did majority vote to assign a label to each annotation. Basically, we are having 78 slides for different patients, and the age was in an average 68. The survival was 51 months, and the number of patients who died during the collection of the data was 34 patients, 44%. Most of the patients, they were in stage 2 and stage 1 and 2, and the grade tumor differentiation was mostly grade 2 and grade 3. And also we collected the vascular invasion from the pathology report, and it was around 50%. It was indicated that there is a vascular invasion within the tumor. So what we did is we built the machine learning algorithm. We prepare our data set as you see here. We have the whole slide, we divide it into small patches, and then we extract these patches at multiple resolution because we want to mimic what pathologists are doing. You know that pathologist looks at the histology slide at different magnification, and that is really necessary to understand the tumor. And that's what we try to do with the machine learning. We train the machine learning on 20x, 40x, 10x, and 5x. To make sure that we collected the pattern architecture, we understand the tumor as possible. And then we trained the deep learning model, and then finally we did the classification on the whole slide image. Then we did our analysis. Let's have a look at some of our results. So here you can see this is the histology slide, digitized histology slide, and this is after the classification. And you can see here the colors refer to different patterns. So this is a multiple pattern within the same slide. And you can see here, for example, the yellow region refers to the SNR pattern. The blue region refers to the lipidic, and so on. So now we are able to quantify automatically what is the percentages of each pattern. Here are another examples. So for example, here you can see the blue region is the solid. So this is a solid predominant slide. Another example here, this is the papillary. So this is a papillary predominant, and so on. So once we got our quantified pattern per slide, we are ready to do our analysis. So you can see here this bar chart shows that the number of cases where this pattern is the predominant pattern. So for most of the cases, SNR was the predominant pattern, followed by lipidic, solid, and the papillary. Here there is an interesting outcome or notice that we find in this study that there were no micropapillary predominant pattern. And our explanation of this is that micropapillary is a really critical pattern, and if it shows up in a slide with a very huge percentage, that means it's a really advanced stage of the tumor. And on this figure, you can see these are the percentages. So you can see that SNR comes in a percentages, goes from around 1 to 10 percentages of the slide. Lipidic, for example, goes from 1 to 10 as well. Micropapillary comes into a really small percentages. But however, even a 5% of micropapillary is related to disease outcome. So it's really important to quantify micropapillary, even if they comes in the slide with a very small percentage. Similar for papillary and solid. So, so we were interested to look into the relationship between this quantification and patient survival. So we have the overall survival for the patient, and we look into their survival, and you can see here, for less than 3 years, so 50 months, less than 3 years, lipidic and the lipidic and SNR, they were having, so the blue and the bluish coral, which is papillary and solid, you can see here they are having good survival compared to the SNR and papillaries. This is for 50 months, which is 3 years or less. So we can make a 3-year survival prediction by using this quantification. So what we did is we combined the percentages of all these 4 patterns, and then we built a machine learning model where we trained, where we want this machine learning model to predict the survival based on this quantification. So these are this line shows the predictions of our model. So these were predicted as having short-term survival, and these were predicted as having long-term survival. And you can see there's a great separation between these curves with a great p-value. So this was one of our studies. Another study we do is the nuclear normometrics to predict survival in lung adenocarcinoma. So we did the same with the same data set. What we were interested to know is there is a relationship between nuclear morphometric features such as size, shape, irregularity, and patient survival. So we tried to first segment the nuclei and then extract the morphometric features and then summarize these features for the whole slide and then predict the survival. So you can see here for this slide shows you the nuclear color intensity. So the intensity of the color and the hot spot here mean that there is a high value of nuclear intensity, and the bluish area means the low intensity of the nuclear color intensity. Similarly, for nuclear spatial distribution, so how the nuclei are distributed along the tumor, and you can see here the hot spot here means that there is a high distribution of the nuclear tumors. Similar thing we did for the nuclear texture, and then we tried to build a machine learning algorithm also to predict patient survival based on this information. And we train our algorithm, and then we test it again, and then we find that there is a great separation between better prognosis and worse prognosis. Better prognosis who has good survival, and worse prognosis who have lower survival. So in conclusion, we can see that computational pathology can benefit from machine learning. It can assist pathologists and provide a second opinion. It can extract existing biomarker or new biomarkers, can be also discovered with the help of machine learning and AI, and of course with the support from pathologists. Thank you so much.
So I have a couple of questions.
Yeah, sure. Go ahead.
So use one scanner for your algorithm.
Yeah.
So how are you going to address the generalizability of your algorithm? For example, if you want to deploy it in say different institution, that they have multiple scanners. I know that you did the algorithm, which is great that you have multiple applications that you train your algorithm, right?
Yeah.
But how are you going to address different from different institutions, different ones?
Yeah, I mean, this is a really good point that we need to make sure that the machine learning algorithm is generalizable, which means you can apply it to multiple data sets, regardless of the staining situation, regardless of the lifetime of these slides. However, in this study, we were limited to one data set from one hospital. But of course, we need to test it on another data set from another hospital with different scans.
Type of tumor. You see it, right?
Yes, ResNet. Yes, ResNet. We selected ResNet. ResNet, yes. ResNet at that time was really the successful one. I mean, it is not a very huge deep learning model, and it also was being shown successful in similar approaches, in similar problems. And we compare it with BGG and other deep learning algorithm. It was the one that gave us the best result.
What was your training settings?
I can't really remember from the top of my head, but 20% for testing for sure. Yes, it is not more than that. Yeah.
Thank you.
You're welcome.
Certificate. So
I didn't order.
Oh,
Okay. Thank you so much. Thanks a lot.
looks like that Rotterdam is also here. We have some track issues, so please right now. Yes, you get that, right? Yeah. So the talk is about newer therapeutic target and inflammatory bowel disease. It's okay. So click on this. Thank you. Please. Yeah, this one. Yeah.
Yeah, hi, hello everyone. Good afternoon. My name is Dr. Srikanth. I'm working as a physician in the UAE. So today my topic is update on new therapeutic targets in inflammatory bowel disease. So IBD is a complex, uh, severe. Um, I'm sorry, how can I zoom it?
Sorry.
Zoom. Zoom.
Oh, okay. You can do this. That's the maximum size.
Yeah.
Yes.
Sorry.
Yeah. So you can read from this one.
Okay.
Okay. Okay, slideshow.
This is fine.
This one?
Yeah.
Let's see. Just give it 1 second. You good?
Yeah, yeah. Thank you. Sorry for that. So IBD is a complex, severe chronic inflammatory disorder affecting the gastrointestinal tract, can fluctuate and resist standard therapy. So IBD research, biomarker identification, pathophysiology, and molecular mechanisms exploration have led to prospective therapy targets that can alter the disease early course. Exploring newer, more effective medicines that reduce flares, induce rapid remissions, and improve care is important. Non-biologic medicines alleviate symptoms but do not modify disease progress. Biologics induce and maintain remission of both Crohn's disease and ulcerative colitis. Drugs targeting different stages of disease process to halt the progression have been identified, and novel therapy targets include improving epithelial barrier functions, inhibiting pro-inflammatory cytokinin, limiting inflammatory cell trafficking, and boosting regulatory T cell function. So as you can see, the figure 1 shows the major innate and adaptive immune cells implicated in the IBD pathogenesis, and the cytokines produced by respective cell subsets in the afflicted mucosa. So chronic inflammation results from cytokine activation and maintenance, as well as limited regulation of anti-inflammatory cytokines like IL-1 and TGF-beta. Inflamed intestines boost MADCAM1 expression, which recruits gut-specific T lymphocytes to the lamina propria. So IBD is characterized by altered effector T cells, elevated B cells, antibody production, and increased pro-inflammatory mediators. So what are the newer therapeutic targets? Currently successful IBD treatments target tumor necrosis factor alpha, which includes infliximab, adalimumab, cetralizumab, and golimumab. There are certain integrin blockers like vedolizumab, which affects gut T cell homing, and some JAK inhibitor, which is the tofacitinib, and stikinumab, which interrupt effector T cell differentiation. And there are also a few drugs recently approved, which is risankizumab, which is IL-23 P19 subunit inhibitor, and lymphocyte homing modulator ozanimod. There are a few drugs which are nearing approval from the FDA, which is JAK inhibitor filgotinib and TLR9 agonist cobitolamab. So there is also a drug for ulcerative colitis, which is very good and approved recently. It's upadacitinib and JAK kinase inhibitor. So ulcerative colitis treatment with fecal microbiota transplantation is also promising, but still there are many issues which remains. So in conclusion, newer, better and safer IBD treatments are needed. Treat to target, early intervention, biomarker identification, personalization, and disease prevention are new therapy approaches. Novel medicines, microbiome consumption, and stem cells targeting disease pathways in IBD pathogenesis enable new therapeutic targets. Thank you very much.
Any questions? Yeah, okay. So I believe the next two most our presenters, I think they're gonna will present tomorrow. So next speaker and keynote speaker is Dr. Fatima Agarish. She's assistant professor at the University of Chicago and associate medical director of blood bank and transfusion services. And she's gonna talk about a tale of one academic transfusion service in response to blood shortage around COVID-19 pandemic.
Hello, everyone. Thank you for inviting me to this meeting. I'm Dr. Alderwish. I'm a clinical pathologist and assistant professor at the University of Chicago. I'm also the associate medical director of blood bank and transfusion services, and more recently, associate director of clinical pathology quality. So today I'll be sharing with you our experience with the blood shortage around COVID-19 pandemic and how that impacted our services. University of Chicago is an adult level 1 trauma, pediatric adult trauma as well as it's a large transplant center. I have no financial interest concerning material discussed in this presentation. I'll be explaining the impact of COVID-19 pandemic on the blood supply and what medications that can be done, including planning for shortage. So having a blood preparedness plan is always a good thing. And finally, we'll share with you our experience at the University of Chicago. And before that, I wanted to go over the COVID-19 timeline. So in December 2019, pneumonia-like illness spread in Wuhan, China, and later on, that illness was recognized as SARS-CoV 2019. So here's the timeline in the US. So it's hard to read from the slides here. So in first, it was not recognized as a COVID-19. Later, it was given this name by the CDC. The FDA developed or gave an emergency use authorization for the first kits to diagnose the COVID-19. And then they started screening, recommending screening all passengers coming to the United States. And fast forward, they also gave emergency authorization for Pfizer to start working on the vaccine, and Moderna as well. And then finally, this was kind of put together around the end of 2020, where we had access to both Pfizer and Moderna vaccines in the US. So this timeline, keep it in back of your mind when I review the blood utilization and the MTP activations around that time and the blood collections. So this was the case in most of stores in the United States around after the declaration of the pandemic. So there was a public panic around that time, along with supply chain issues. This was not just related to paper towels and tissue towels and baby diapers and everything. Blood also was impacted in this case. So we got our first notification from the American Red Cross, which is the major blood supplier in the United States, letting us know that there were over 4,000 blood drives were canceled because of the pandemic, because a lot of businesses, schools, and universities were closed at that time. So this resulted in over 140,000 fewer units in the entire inventory of the United States blood banks. Why do we need blood? We need blood because it has components that are important for our survival as human beings. It has red blood cells, which carry oxygen and prevent anemia and tissue ischemia. Platelets and plasma are important for maintaining hemostasis, and also volume. An average adult weighing between 70 to 80 kilos, their body may have anywhere between 4,000 to 7,000 mLs of blood. So that is a volume you need to compensate for from other ways, even give fluids or give whole blood. We don't transfuse whole blood usually, unless it's in a battlefield or in major trauma. We rather give components. So we have components of the blood. So we have packed red cells, plasma, cryoprecipitates, and platelets. So think about this as a specimen. After centrifugation, you have the liquid part, the plasma, and then you have the buffy coat where you have the platelets, and then red blood cells with sediment below there. So in the United States, we don't have a centralized blood collection system. We have major and minor blood collection facilities. The American Red Cross and the America's Blood Centers are the major blood suppliers in the United States. We also have hospital blood donation centers, like our hospital does. And because of that, we kind of survived the blood shortage for the most part, compared to other hospitals in the region. They're also for-profit blood donation centers as well. Then we got another notification from the American Red Cross, which is our major supplier to our hospital, with over 90% of our inventory coming from the American Red Cross. In this email, they mentioned that the supply remains strong and stable. And this was in April, not 7 or 9, can't tell. That didn't last long because elective surgeries now were being resumed. So you have demand more than supply. And that's put the hospital into shortage again. The critical shortages times were during the initial COVID wave in between March 2020 and May 2020. And then there were the Delta surges, the Omicron surges, and always we have this issue every year during the holidays, the Thanksgiving and the Christmas time. We also have been in restricted allocation from the American Red Cross, meaning that instead of getting like 100 units of OPAS or ONEG per week, we've been given like 20 or 30 units per week. So that restriction of ONEGs, RBCs started on the 29th of May of 2022. That was around I think the Omicron or the Delta surge, and that continued to date. And the OPAS RBCs also are under restricted allocation since January of this year to date. And this is the national blood supply trend for the red blood cells from 2018 up to 2023. There's some surges in blood collections in 2018 and in 2020. And those surges means that the public or the US population now are presenting to donate blood. The 2018 surge was after appeals for the public to donate blood after the Las Vegas unfortunate shooting. And the second one in 2020, that was after the general surgeon pleaded the public to present and donate their blood. So this proves to you that the public do listen to media and do listen to the authority. But as you can see here, there are two small waves there where the supply of OPAS was slightly above the optimal level. So we're still like shy from it to date. And this is our blood collection facility data. So we also see the similar increase in influx of donors around the same times there. So here I'm providing data from pre-pandemic, so the December 2019 up to April 2023. And we have two influx of donors coming around that time. So in our hospital, we rely on the employees, the physicians, nurses, technicians, students. Our hospital is based within the university campus. So we have access to emails of all those people, and we send mass notification, and people do come and present. So that saved our hospital from diverting trauma and from canceling surgeries. It's important to recognize blood shortage and prepare for it ahead of time. To prepare for it, you need to have an understanding of the hospital inventory, the order fill rate, the blood supplier inventory if you have more than one supplier and you rely on others. Also understand the population that you're serving. So high-risk patients who probably need more transfusions or who are transfusion dependent, like hemonc patients, trauma, complex surgeries, especially liver transplants, AAAs, and high-risk OBs. The American Red Cross divides blood shortage by severity and duration into mild, moderate, and severe. So mild, where you have less than 25% of the expected inventory, and that could, with expected recovery in 12 hours. Moderate, when you have less than 50 of expected inventory and recovery is expected within 36 hours. Severe, when you have less than 75% of your expected inventory, and that persists beyond 36 hours. Preparing for blood shortage is a requirement of many blood societies and by regulations as well. So there are many standards according to AAB, which is an international society for blood banking. So standard 1.4 says that we need to have an executive management to ensure that the facility has policies and processes in place to ensure that you don't go into shortage and you know what to do basically. And standard 5.15.21, for example, tells us that we can switch the RH type of patients, like the RH type that we give to patients, even emergency situation, but we have to have a policy and a plan like when to execute that as well. So we do have our policies for both situations, management of critical blood shortages, and also switching patients RH type as well. We try to preserve giving RH negative to female of childbearing potential when they're presenting for trauma, to prevent anti-dealuminization, which can lead to the anti-D can be associated with hemolytic disease of fetus and newborn. So we're trying to prevent that, but at the same time, if you have a shortage, it's permissible to make that switch as long as you have a plan. That being said, the strategies can be summarized in this slide. So you have to have a blood shortage management plan, decrease transfusion volume. There are many steps you can do to do so. Optimize the blood product use, expand the inventory, and communicate well. I won't go into further details. I will go in some details in some of those mitigations, but at a high level. So for the blood shortage management plan that we developed in our hospital, this was based on discussions with multiple teams, multiple services coming together, deciding on what the hospital inventory should look like and how is that reflected into what level, and when also having conversation with the blood suppliers about their current state and what they anticipate to have as well. So level 0 is normal operations. There's no shortage in the blood bank inventory, the hospital inventory, blood supplier is not impacted. So that's the ideal situation. We're not there. Level 1, there's possibility of local shortage. The inventory in the hospital is good, but the blood supplier is impacted. So then we have to have a plan. So part of this is communication with the transplant team, surgical teams, and daily inventory checks, and relay that information to high users or high leaders in those various areas. We're currently at level 1, but we've been at level 2 and 3 and 4 as well. Level 2, when the blood inventory is less than 75% of the desired level, there's significant restriction of the blood standing orders by the blood supplier. In this case, we're going to have some more management. We're going to restrict giving blood to certain patients, like not restrict giving blood, but minimize the number of units, minimize the volume, especially to pediatric patients. Level 3, when the inventory is less than 50% of the desired level and there's significant restriction of the blood standing orders by the blood suppliers. In this case, we're now going to consider using Rh positive RBCs for any patient, regardless of their age and gender. As I mentioned, we tried to restrict that to Rh negative patients who have anti-Ds or female of childbearing potential. This is level 4. We have more plans and policies in level 4, and we've been at level 4 for 48 hours, and that was our nightmare for a whole year. And then the recovery phase, slowly going back to normal operations. So one of the strategies is to decrease transfusion volume by doing transfusion auditing. That could be prospective, retrospective, so following the transfusion guidelines and also reinforcing those guidelines to colleagues and reaching out and asking, do you have a CVC? Do you have any support for your transfusion? If you don't, we'll need that before we approve the units for you. Also, we have a computerized point of order entry. So there's a best practice alert which pops up after a physician or provider places an order for a unit, tells them, hey, you have a normal hemoglobin. Why do you want an RBC? That kind of kind of an AI situation there, but it helps as well. Trying to give blood product alternative like Kcentra for plasma, Restab for cryoprecipitate. And here, the picture down here is a screenshot of our red blood cell order, and we have a banner there letting provider know that there's a shortage and still continues. Also, intraoperative management of anemia. So trying to be prospective in this case, So the picture down there is showing acute normal volemic hemodilution, or ANH, where patient's blood is collected and volume expander is given to patient like normal saline, and then patient goes to surgery. That blood is transfused back to them. So that's a way to conserve the inventory. In the upper picture, this is cell saver. Where patient is actually on the table in the OR, and their blood is collected, filtered, mixed with anticoagulant, and washed, concentrated. And when they're about to close, they give back the patient their own blood. So we have both techniques in our hospital, and that help conserve blood units. Part of that is also adhering to the transfusion triggers, following the recommendations, adjusting red blood cell parameters as well, if the hospital does have apheresis unit. Optimizing blood product use, maintaining a 7-day supply, minimizing waste, limiting thawing, because if you thaw plasma, it's good for 5 days. So if you don't use it, you lose it, basically. Group A plasma now is becoming more of a universal type of plasma to be given in trauma situations. AB is the universal donor because they don't have isohemagglutinin, but AB is the rarest blood group there. So group A now is becoming more popular to be used and shown no hemolysis or very minimal hemolysis. Expanding in the inventory by increasing in-house collections, promoting local blood drives, give half unit and check for hemoglobin level, check for platelet count rather than giving full units to patients, modifying the massive transfusion protocols, and using whole blood as possible. We do have whole blood in our institution that is given to a specific population of adult trauma patients. In the US, more than 38% of the population are eligible to donate. However, less than 10% do so. So that's another gap that we all need to work on to increase awareness about the importance of blood donation. Blood is a human blood-derived product. So if donors don't present, we will have a shortage in that product. Communication is essential. We do send daily inventory emails to high user areas. We have a banner in the electronic medical records. We do send mass notification. I have an app in my phone. When I'm on service, I can send a mass notification that will generate a page, an email to everyone in the hospital, letting them know that we are in a severe shortage, divert trauma patients, cancel surgeries or postpone them. So luckily, I did not have to use that app in a while. Also, we do have some information about blood shortage in the intranet, in the university side and the hospital side, and information about how to give back and donate as well. We have not been successful in discussing the futility of MTP. So when patients are presenting with severe hemorrhage after a car accident, after violence, and clinical providers, our colleagues in trauma, are trying to resuscitate the patients with tons of MTP packs. So MTP contains 6 red cells, 6 plasma, and 1 platelets. So if one patient is using 6 MTP packs, that's like depleting the entire inventory of a blood bank. So we've been in discussion with our colleagues about that. We cannot pull the trigger and say no unless we reach like certain levels in the hospital. And this is the blood utilization from our hospital pre-COVID in December 2019, during the initial surge in March and May 2020, and then after that. You see that blood utilization had some plateauing in between, where people staying home, where surgeries were canceled, but then we see a surge in especially red blood cells around January of 2021. So people were kind of back to normal. They just got their vaccines in December 2020, and now they're kind of back to their daily transfusion. And this is the massive transfusion protocol activations from the pre-pandemic to during the pandemic and now as well. Violence, car accidents were not slowed down. As you can see, actually, we had surges in July and August of 2021. So there is an increase even from pre-pandemic cases of MTP activations. And as I mentioned, AAB is an international blood bank society that tries to survey blood collection facilities around the US. And this is one of their surveys that they sent us this survey earlier in the pandemic to see what our organizations are doing about preparing for blood shortage, because they were predicting there will be a severe shortage coming along the way, and what modifications that can be done there. FDA also modified some of the requirements for blood donors. There's certain criteria for donors to be eligible, certain criteria for them to be deferred. So they made historic changes to their guidelines because of the severe shortage that the United States was facing. And one of the things that they also did was talking about centralizing the blood bank in the United States. But there are some optimistic and pessimistic people and controversial opinions here and there about it. So basically, if the Midwest region has more blood, they can give that blood to the East and so forth. But lack of a central blood bank will make that really hard to do. But that's one of the suggestions the FDA had provided, and people are actually thinking about it. They also created a new act, which called Pandemic and All Hazards Preparedness Act, the PAFA, in 2023. So basically, blood banks and blood bank organizations and blood collection facilities, they need to work together based on this act into ensuring that there is enough of blood for every citizen, for every resident coming for surgeries or transplants. With that, I conclude my presentation. This is the Cloud Gate from Chicago downtown. So if you happen to come there, don't come in winter. It's a beautiful place otherwise. Any questions?
That okay, the blood that you donate has for past today saved a life. I think I just want to suggest you that it's a good system to establish in your system. So in a sense, it can give the person with some sort of like action.
Yeah.
Yeah.
Yes, we do that. We do more than that. We actually give them a lot of incentives. So in the US, the donors are unpaid. They're altruistic donors, like in most places in the world. But we give them some incentives like vouchers to gift cards and parking validation. And also we put their names in, we call it the Wall of Fame. We put their name there. So if they're regular donors, especially if they were platelet donors, because for platelet donors, they need to stay on the machine for 2 hours. We give them more incentives and they can binge on watching Netflix around that time, and we pamper them. It's the happiest place in the hospital. So, yep.
More questions? Right, thank you. So, each you please double check on this page for the calculation, but I can find after the one. Sorry. Thank you so much. Thank you. Okay, so the final presentation of the exhibitor, Dr. Santosh Gurdev, and he's going to present the next generation reporting and consultancy system, digital diagnostic beyond barriers.
Sorry. Hello everyone, my name is Santosh Gurudev and I am for CR Diagnostics International. Today is it's last speech of the day. I'm sure you're all tired, but I'm a radiologist by profession, and you might be thinking what a radiologist is doing in a pathology conference. Okay, to start off, my wife is a pathologist and I'm coming on her behalf. Roughly about 7 years back, we started a tele-radiology services, and in the last 2 years, we have started digital telepathology services, and our company is called as CR Diagnostics International. So we have, sorry, okay. So we have our offices based in UAE in Ajman, and our head office is in UK in Liverpool, and in India as well as in Bangalore. So what do we do? I'm not going to go into the details of teleradiology. So I'm sure we have gone through enough telepathology or digital pathology since morning. So why is it that I am presenting here today? So we have all done through the digital slides, scanning, and then transmitted across different places being reported, and then the report sent back to the original reporter, original clinical referral. One of the important challenges is to build a team of highly qualified pathologists who have got an excellent high standards of reporting across the barriers, whether it is in US, UK, Australia, or in Southeast Asia, wherever it is. We want a uniformity and standards of reporting system. What the next step would be is to have a rigorous quality assurance. It's maybe that in a smaller country, the quality may not be as good as what is available in the UK or in Australia. And the next thing is the turnaround time. If Dr. Hassel was informing today that quite a few of the breast surgery specimens don't even reach a pathologist. And that's pretty much the case everywhere. Pathology specimens never reach the time because the report may not come in time, and it never goes through a proper channel of what needs to be done next. So even in remote access hospitals, if you go into Southeast Asia or in Middle East, some of the Lebanon or in other countries where we have seen a lot of the smaller hospitals don't have the high-end technology. So what are we doing is to do this digital telepathology services. So we take the pathology slides, and we have a company which scans the digital the slides into digital images and sends them into the central server. In the central server, we download them to our reporting pathologists, histopathologists, and cytopathologists, and we produce the reports and then send them back to the original referring clinicians. And we also do what is called as an MDT. So for those of you who are trained or who are training in US, UK, you may be aware of the multidisciplinary team meetings, especially in cancer staging and cancer treatment. So there, a team of histopathologists, cytopathologists, radiologists, oncopathologists, oncosurgeons, general surgeons, they all sit together and discuss each and every case that is suspected or deemed to be suspected cancer and come to a consensus conclusion as to what is the best mode of treatment or method of treatment for a particular patient. For example, a stage 4 patient need not have a surgery. At the same time, a stage 1 patient did not have a chemotherapy. How do we decide this? We need experts. And where do we stand? We stand in the process of delivering MDT, the MDT discussion that happens online with the team which I just mentioned to give a consensus opinion. Currently, we have MDT meetings for renal, gastroenterology, hepatobiliary, thyroid, and breast. And we are now incorporating into other fields as well. And our company gives a second opinion as well, that if a pathology specimen has already been reported, if they can transmit the digital images to us, we can give a second opinion based on the subspecialist and super specialist areas. For example, neuropathologists or hepatobiliary pathologists, who are very few in the world. So we have got a few of them who can do that one. And one of the other things that I need to tell is that we have a rigorous quality assurance and a fast turnaround time. So telepathology, as I said, we do oncology and non-oncology reporting that includes inflammatory bowel diseases, thyroid cases, and things like that. And they are all done by expert certified pathologists. And from the radiology point of view, even the radiologists are highly specialized. Although I'm not going to go into the radiology domain of that one. And most of us are either trained in UK or US. So this is the telepathology workflow. Most laboratories or hospitals will have a laboratory which can produce a slide. Once the slide has been processed, if you leave it at your doorstep, and literally at your doorstep, we will make sure that the slides are collected, and we have the facility for scanning the slides, digitizing them, sending them to the central server, reporting them, and then sending back the report directly back to your service. So this is the workflow. So from up to this point, these two, grossing and the specimen collection, has to be done by the local hospital or the local laboratory. Once the slides are ready, we take care end to end from collecting to issuing the report. So as I said, this is a multidisciplinary team meeting. As I said, we have the renal, hepatobiliary, thyroid, and breast. And soon we will be introducing other specialties as well. Second opinion reporting, I've just through the quality and clinical governance, I've just made sure that one. Turnaround times, we can get the reports done in less than 24 to 48 hours with the ready slides if they are ready. And if it is a routine slide, we can get them done within less than 5 days. And the time of starting the TAT will be the time when we get the slides in our hands. And from there, it is 24 to 48 hours and then up to 5 days. For anybody who is already having a histopathology laboratory or a hospital where they need the services, we can give free trials. The free trials will last for 30 cases or 10 days, whichever is earlier, and we will arrange everything. And we are happy to take the samples ourselves and scan it and get everything done for you. And that comes to the end of my short talk. And my stall is just at the corner. If anybody wants to have any questions, they can ask me, or they can come to my stall and ask my details. Yeah.
So the services, they provide you the slides from different institution, any institution or client, and then you can digitize those slides. What is the turnaround time for those slides?
From the point where we do the digital, the physical slides, to the point where the report is generated, it may be between 24 to 48 hours for urgent ones, if it is really urgent, or up to 5 days if it is non-urgent.
So when you say by report, meaning that some pathologists will read the
Yes, the pathologist will read, issue the good report.
Okay.
Include staging. And if we have radiology images as well, we can combine that, present to the MDF, the full case, in the following, usually we have one MBD per week, so you can do that within the findings.
So do you integrate the lab information system with your system? Or how that, do you integrate the lab information system for that client with your like imaging image?
Yeah,
Or-
we need research on this. If you have resected thyroid, the clinical experience, whether the patient was hypothyroid or it was just a glass or we are resected something. If we know all that, then we can issue products safety as well.
So where do you see this service, like, providing this service, how is that gonna help, like, is this service in Europe?
Yeah, it's everywhere. It's multinational. As I said, we have got multinational office. Currently, they have got stuff in Bangalore, in London, in Dubai. We have just recently signed up, and the scanning can happen in a place which is not very far from here, which is Jeddah. So we have got a tie-up with a company who will take the slides, scan them, and send it to us.
But how are you handling the immunohistochemical issue? But you're just getting HD slides when you.
Yeah, it's like once we
If you need a special stain or whatever, then it goes back to the original.
say we need IHC, then or even if we need extra levels. In the second levels.
What if they don't offer that service?
Sorry?
What if they don't have that stain or that antibody or? Then
At the moment, we have got only 2 hospitals who are able to do the IHC. So I must say that it is not a perfect solution, but the 2 hospitals which we are doing, we pretty much get about half a dozen IHCs per month. Only half a dozen. So, but if it is a big service, if it is a national level, then obviously the services will be there and we can do that part.
So do you charge per service for that results, or do you also charge for scanning it?
That is included everything. Right.
Okay.
We pay the scanning services.
So your service is for any institution that have maybe some lack of or shortage of pathologists, that's my understanding?
Yes, that's right. We only need the slides.
Okay.
We don't do the wet crossing, we don't do the specimen collection from the hospital. We only do, once we have the dry slide, we can from there to the point where it comes to the computer with the full 3D report is our responsibility.
So the pathologist who create that report is like working with different institutions or that work only with, okay.
Yes.
So you're contracting, kind of contracting with different pathologists.
We have full of
from all.
Yeah, we have got 2 US-based pathologists. We have got 5 UK-based pathologists. We have got 12 Indian-based pathologists, 1 Singaporean and 1 Malaysian. So we have got a pool. And we are recruiting more. If anybody wants to join us, we are more than happy to join.
Thank you so much. Any other questions? Okay, so I think we conclude for our first day. So see you tomorrow.
Yes.
Thank you.